On the 1st of September, 1953, a 27-year-old man sat upright in a chair in an operating theatre in Hartford, Connecticut. The local anesthetic had dulled the skin of his scalp but left him awake. Above him, a surgeon named William Beecher Scoville was looking at the readings from a set of electrodes placed against the medial surface of his temporal lobes. The surgeon had been hoping the readings would show him exactly where, in this man's brain, the seizures that had ruined his life were coming from. The readings showed nothing of the kind. There was no focus, no discrete lesion, no small bright region he could remove and hope to leave the rest of the man intact. There was only the wider territory of the limbic structures, stretching back along the inside of both temporal lobes, suspicious in a general way, but silent as to any more specific guilt. Scoville made his decision. He picked up a suction device and began to remove tissue, working back from the temporal tips on both sides of the brain to a distance of roughly 8 centimeters. Somewhere inside that 8 centimeters, in each hemisphere, lay a small curved structure about the size of a child's little finger, shaped like a seahorse, named in the 18th century for that resemblance, the hippocampus. Neither Scoville nor anyone else in 1953 knew in any complete way what the hippocampus did. They had suspicions. They did not know. The young man in the chair was named Henry Molaison. He went into that operating room with seizures so frequent he could no longer work. He came out of it a few hours later, with his seizures reduced and everything else in his life, quietly and without ceremony, ended. He would live another 55 years. In those 55 years, he would meet thousands of people. He would not recognize any of them. He would be photographed, tested, interviewed, studied. He would be moved to a nursing home. He would do the same crossword puzzle over and over, every day finding it fresh. He would watch Amtrak trains pass by his window in a town called Windsor Locks, and each train would be the first train he had ever seen. And during all of that, every afternoon, every morning, every slow Connecticut summer, he would be teaching neuroscience almost everything it now knows about human memory. It is hard, from the outside, to imagine what this was like. The difficulty is not that the experience is exotic. The difficulty is that the experience is almost entirely the one thing you yourself are doing right now in order to listen to this sentence. You are hearing a string of words. The earliest words in the sentence are being held somewhere in your mind, long enough that the later words can be integrated with them, so that the whole thing becomes meaning rather than noise. That holding is a function. It has a location. It depends on the continuing cooperation of structures in your medial temporal lobe that, a few hours after Scoville's operation, Henry Molaison no longer had. If he had been told this sentence, he would have understood it as it arrived, word by word. He would not have been able to tell you a minute later that anyone had said anything to him at all. Henry's case is the foundation on which the modern science of memory was built. Nearly 12,000 published papers reference him. More than 100 researchers spent significant portions of their careers with him. Two of the most consequential insights in 20th century brain science came out of his operating chair. First, that memory is not a distributed and intangible property of the whole brain, as most scientists in 1953 assumed, but a set of functions localized to specific structures that can be removed, with devastating and specific consequences. Second, that what we call memory is not one thing at all, but at least two, with different neural substrates and different rules, and that these two can be separated cleanly enough that one can be destroyed, while the other continues to operate in the same skull. Both of these insights were purchased at the price of Henry's life. This is a fact that the field has lived with in varying degrees of comfort ever since. The story of how the insights were extracted from his tragedy involves a young Canadian neuropsychologist taking a train from Montreal with a piece of paper and a mirror in her bag. It involves a cerebral anatomist in San Diego, half a century later, dissecting Henry's brain into 2,400 170 micrometer slices, while a webcast ran for 53 hours. It involves a journalist, the grandson of the surgeon, returning to the case decades later to ask questions that many of the surgeon's successors would rather not have heard. It involves a woman at MIT who spent 46 years in the company of a man who never, across any of those years, learned her name. But underneath all of that, underneath the mechanism and the people and the ethics and the histology, there is a quieter question. It sits at the bottom of the story and never comes to the surface. If a person wakes every morning unable to carry any part of yesterday into today, and goes to sleep every night unable to carry any part of today into tomorrow, then what precisely is the thing that persists from one end of a life to the other? What is the continuous thread if the thread of remembered experience has been cut? 55 years is a long stretch of time to occupy without that thread. Henry occupied it. What it was like for him to occupy it, we cannot know. What we can know, what the science has allowed us to know, is that the absence of that thread does not, in any obvious way, dismantle the person. Henry was funny. He was kind. He was patient with the researchers who kept asking him the same questions because for him, the questions were always new. None of that required the continuity we usually assume is the scaffolding of a self. None of it required him to remember that he had been funny, kind, or patient yesterday. These are not comfortable observations. They suggest that the thing we think of as ourselves is held together by something stranger and more local than a continuous narrative. Henry's case does not answer what that stranger thing is. It simply reveals that the question exists. Over the next 2 hours, we are going to stay with him. We are going to follow the arc of his life from the quiet Connecticut childhood before the bicycle accident, through the years of worsening seizures, into the operating room on the 1st of September 1953, and out the other side. We will sit with Brenda Milner on her first trip from Montreal to meet him in April of 1955, when she understood almost immediately that the young man in front of her was going to change what her science could ask. We will watch her put a piece of paper with a 5-pointed star in front of him over the course of 3 days, and see his hand learn a motor skill his mind could not admit to having practiced. We will walk with him into his room at the Bickford Healthcare Center in Windsor Locks, Connecticut, where he lived the last 28 years of his life, and watch Amtrak trains pass his window. We will stay with Suzanne Corkin at MIT across the 46 years of her work with him. We will look at the small orbitofrontal lesion in his left frontal lobe that was not reported during his lifetime, and that became, in 2014, the source of a painful public reckoning. We will stand in the dissection suite in San Diego while 2,401 thin slices of Henry are photographed, and at the end, we will go with him into the last afternoon of his life, December 2nd, 2008, 5 minutes past 5. And we will try not to answer the question at the center of his story, but to hold it steady enough to see. Before we go any further, if you're enjoying this and want to keep finding these kinds of long, patient documentaries, you'd be doing me a quiet kindness by subscribing. It genuinely helps the channel. And I'd love to hear from you in the comments. Has there ever been a stretch of time in your own life, an afternoon, a day, a whole long drive, that for some reason never got encoded? A chunk of experience you know you lived, but cannot access? I find these moments interesting because they are the closest most of us come to what Henry lived with, and I want to hear about yours. For the moment though, let me take you back to the origin of Henry's troubles, to a street in Manchester, Connecticut in the mid-1930s, and a moment involving a bicycle that may or may not have been the reason for everything that came after. Right now, as you listen, the same structures that Henry lost are quietly sorting this story into a form that will outlast the listening of it. Some of what I'm saying will be with you tomorrow. Some of it will not. The selection is already being made. You are not being consulted. This is the ordinary miracle of having a hippocampus, the one Henry, after the 1st of September 1953, no longer had. The bicycle is where the story usually begins, though the story of Henry Molaison's epilepsy, like most stories about the brain, probably begins earlier than that, in places no one ever thought to record. There was a family history on his father's side, several relatives with seizures going back at least a generation. There was a minor head injury in early childhood, the kind of fall whose details are lost in the ordinary forgetting of boyhood. And then, somewhere on a residential street in Manchester, Connecticut, during a summer afternoon in the middle of the 1930s, a bicycle hit him. He was 7, or he was 9. The sources disagree, and the disagreement is itself a small piece of evidence about the era. In the original 1957 paper that made him famous to science, he was 9. In later accounts, drawn from family recollections, he was 7. The age in a case report from the 1950s was rarely the age in a family's memory. Medical histories back then were written the way weather was reported, with a practical rather than a forensic precision. And it is only because Henry's case became so consequential that anyone went back to reconcile the small discrepancies. They were never fully reconciled. We know the bicycle happened. We know it knocked him unconscious for about 5 minutes. We know he suffered minor convulsions shortly afterward and carried away a laceration on the left side of his forehead that would still be a faint mark on his face decades later. What we do not know is whether the bicycle caused what followed, or only arrived in the middle of a process already underway. The seizures began around his 10th birthday, small ones at first, the kind that neurology now calls absent seizures, though in the 1930s and 40s they were more often called petit mal, a French term that reflected both the modest scale of the event and the medicine's long habit of borrowing French for anything it did not fully understand. An absent seizure is exactly what it sounds like. For perhaps 30 or 40 seconds, the person is gone. The eyes may stay open, the body may stay upright. But the continuous stream of awareness that we think of as being present has been briefly interrupted, and whatever was happening in the room during that interruption is not available to the person afterward. Henry himself, in later interviews as an adult, described these early absences in a way that is striking given everything that came later. He said he could half hear what was going on. A little of the room reached him, fragmented and far away, as though he were underwater and the voices were above the surface. Then the absence would lift, and he would be back, and the few seconds that had been taken from him would register only as a small gap he had learned not to remark on. By his 16th birthday, the absences had become something else. Grand mal, the old terminology called them, and this time the French was doing less softening. These were full tonic-clonic seizures, the kind that announce themselves completely. A warning he could not always identify, and then a collapse. Tongue-biting, urinary incontinence, generalized convulsions of the body, unconsciousness, followed by a prolonged and heavy sleep that the literature calls a post-ictal stupor, and which Henry's mother, Lillian, simply called his sleeping it off. She had to stand over him during the worst of it, to make sure he did not injure himself against the furniture. She had to wait out the stupor, sometimes for hours, before he would be able to sit up again and resume whatever the day had been before the seizure took it away. He graduated from high school at 21, 4 years later than the classmates he had started with. It was not that he could not do the work. His intelligence, even in the middle of the seizure disorder, was never in question. It was that the seizures had interrupted his schooling so many times and had made him such an object of quiet cruelty among the other boys that he had moved from one school to another, starting and restarting, until a diploma was finally his. At his graduation, he was not allowed to walk across the stage with the rest of his class. The school's reasoning, as best as it can be reconstructed, was that a seizure during the ceremony would have disrupted the event for everyone else. The decision was made by people who meant well by the standards of their moment to let the rest of the graduates have their afternoon undisturbed. Henry watched from a seat. That is a sentence one can write now, and the writing of it feels small and flat. But think for a moment about what it would be to have waited 4 extra years to finish a thing, and then not be permitted to finish it the way the others finished it. This is the kind of detail that does not appear in the case reports. The case reports note the seizure frequency and the medication levels. They do not note the graduation. After school, he worked. For a time, he was at Ace Electric Motor Company, doing the kind of quiet mechanical work that suits a person who is good with his hands and does not especially want to be the center of anyone's attention. Later, he moved to a Royal Typewriter assembly line, where he was, by occupation, a motor winder, a job title that sounds archaic now, because the thing it describes, the slow and patient winding of copper wire around the armature of a small electric motor, is no longer something most people need to have done to them. It was honest work. It was the work of a young man who, despite everything, was trying to build something like an ordinary life in Connecticut in the late 1940s. He lived at home with his parents. He earned a wage. He waited for the medication to catch up with his condition. The medication never caught up. The drugs available to a person with intractable epilepsy in the late 1940s and early 1950s were a short list, and Henry was on most of it at once. Dilantin, which is phenytoin, and which would later be identified as the agent responsible for the slow atrophy of his cerebellum that his brain would show at autopsy more than half a century later. Phenobarbital, one of the oldest anticonvulsants, a sedating drug that left him drowsy much of the day. Tridione, mesantoin, a patchwork of pharmacology that represented the best the medical community could offer, and that, for Henry, offered only the mildest reduction in the frequency of his attacks. His medical record from 1946 carries a phrase that is worth sitting with for a moment. The prescribing physician wrote that Henry's medications were to continue indefinitely. 3 words, flat and administrative. They meant that the medicine had run out of ideas. They meant that the drugs were doing what they could, which was not enough, and that the doing of it was going to go on forever because there was no alternative. A 20-year-old should not have a file that says his medication is to continue indefinitely. A 20-year-old should have a file that says we will try something else. The frequency increased as he entered his 20s. By the time he was 25, he was having up to 10 minor seizures a day, and a major seizure about once a week. The anticonvulsants had been pushed to doses that left him so sedated that the job at Royal Typewriter, the job that had been his last tether to ordinary working life, became impossible to keep. He had to leave. He went home, to his parents' house, where he now lived as a 27-year-old man who could not work, who could not safely be left alone for long, and whose mother was beginning to understand that her son's life, if something did not change, was going to be a life spent waiting for seizures to come and then waiting for them to pass. It is a common move, in stories like Henry's, to say at this point that he had nothing to lose. I want to resist that phrasing because it is the kind of phrasing that makes the decision he was about to make seem obvious in retrospect. And it was not obvious. Henry had plenty to lose. He had his intelligence, which was intact. He had his parents. He had a house he had grown up in. He had a quiet inner life that nobody who later tested him ever fully knew how to measure, because the tests for such things did not exist. What he did not have was a future. He could see, if he was honest with himself, what the next 30 or 40 years looked like if nothing changed. They looked like the current year, repeated. And so when his family physician, running out of options in the usual pharmacological direction, began to look sideways at the more experimental corners of the medical landscape, Henry was listening. The sideways direction in Hartford in 1953 pointed toward a neurosurgeon named William Beecher Scoville. Scoville had been performing a particular category of brain operation for about 7 years by that point, on a particular category of patient, and the operation had a particular theoretical justification that happened to align with a particular suspicion about Henry's case. The patients Scoville had been operating on were, for the most part, not people with epilepsy. They were people with severe psychiatric illness, mostly schizophrenia, In the period of American medicine, when the limits of what could be done to the brains of the seriously mentally ill were still being actively explored and had not yet been seriously constrained. The operation Scoville had developed was called a fractional lobotomy. It was an attempt to preserve more of the patient's personality than the crude and indiscriminate lobotomies of the 1940s had managed to preserve, while still producing the tranquilizing effect that the older procedure had produced. Scoville had performed something in the range of 300 of these by 1953 on patients whose conditions had failed every other available treatment, and he had also been experimenting with a variant that went deeper into the brain, into the medial surfaces of the temporal lobes, where the hippocampus and the amygdala sit. He had performed that variant, the more radical one, about 30 times before he met Henry. The results in the psychiatric population had been inconclusive. The surgeon was looking for a patient in whom the procedure might be more legibly evaluated, and the family physician in Hartford was looking for a surgeon who might have an idea for a young man with seizures that no drug could control. They met. The meeting itself has not been preserved in any transcript. What has been preserved is the outcome. Henry and his parents agreed to the procedure. The theoretical argument Scoville offered was that the limbic structures of the medial temporal lobe had been implicated in epileptic activity in previous studies of other patients, and that a bilateral resection of those structures might reduce the seizures in the way that excision of an epileptic focus would reduce them in more localized cases. The theoretical argument was not wrong. It was simply built on less evidence than the case required. The previous patients Scoville had operated on with this procedure were not a population from whom clear conclusions about epilepsy could be drawn, and the electrical mapping techniques available in 1953 were not sensitive enough to tell anyone, with any confidence, that the limbic structures were in fact the source of Henry's seizures, rather than merely a region through which the seizure activity was passing on its way from somewhere else. The operation was scheduled for the 1st of September, 1953. Henry arrived at Hartford Hospital. The medical team prepared him. The local anesthetic was administered to his scalp. He was placed in the operating chair, upright, awake. And then William Beecher Scoville, having positioned the depth electrodes and read from them a set of recordings that did not, as the 1957 paper would later acknowledge in plain language, reveal any discrete epileptogenic focus, made the decision to proceed anyway, on the general theoretical grounds that had brought Henry into the room in the first place. He picked up the suction device. He began to remove the medial surfaces of the temporal lobes, working back bilaterally for a distance of approximately 8 centimeters. And the young man in the chair, sedated but conscious, felt nothing in particular because the brain itself has no pain receptors, and the instruments doing the work were passing through tissue that cannot feel itself being touched. What would you have decided if you had been Henry's mother sitting in the waiting room that morning? What would you have decided if you had been Scoville, looking at readings that refused to give you a clearer target and holding in your hand the suction device and the theoretical argument? These are the kinds of questions historical medicine loves to pose in hindsight, and they are not fair questions because they are asked from a position that has the benefit of knowing what was about to happen and cannot unknow it. All over America tonight, decisions like this one are being made. Decisions under uncertainty in operating rooms and clinics and emergency departments by people doing their best with the evidence they have, which is never quite as much evidence as the moment demands. Most of those decisions, the vast majority of them, turn out fine. Some of them turn out the way Henry's did. The medicine of any given decade is built on the residue of both kinds of outcome, and the only honest thing that can be said about the difference, from inside the moment of decision, is that nobody knows which kind you are in until afterward. The suction device in William Beecher Scoville's hand that morning was a piece of equipment he himself had helped to design. This is worth pausing on, because it gives you something of the man. Scoville was not only a surgeon, he was also an inventor of surgical instruments, and several of the instruments that carried his name in the mid-20th century are still in use in operating rooms today, in modified forms. He had a mechanical turn of mind that extended outside the operating room into a private enthusiasm for fast cars and motorcycles, and the colleagues who knew him best used to describe him, half affectionately and half uneasily, as a kind of James Bond figure in surgical scrubs. He drove too fast. He talked too fast. He operated with a confidence that younger surgeons found exhilarating and that older ones sometimes found alarming. His nickname among the nurses and residents at Hartford Hospital was Wild Bill, and the nickname, like most nicknames, contained both the admiration and the warning. He had been born in Philadelphia in 1906, the son of a family that had pushed him toward medicine against his own instinct, which had been to work with engines. He had gone to Yale as an undergraduate, and then to the University of Pennsylvania for medical school. By 1939, he had established the first department of neurosurgery at Hartford Hospital, and by 1941 he had become board certified in the specialty and begun the first neurosurgical residency training program in Connecticut. By the time Henry Molaison arrived in his consulting room in 1953, Scoville was 47 years old, at the height of his technical powers, widely respected by his peers, and one of the most prolific psychosurgeons in the United States. He had performed, by his own late account, somewhere in the range of 300 fractional lobotomies on patients with severe psychiatric illness, along with about 30 of the more radical medial temporal lobotomies that he would propose to Henry. Taken together, this was a body of work that very few surgeons anywhere in the world could match, and it placed him firmly inside a movement that, in the early 1950s, was still accepted as a legitimate branch of clinical medicine and was just beginning, very slowly, to come under serious question. The movement was psychosurgery. The procedure at its center was the lobotomy, which had been introduced into American medicine in the mid-1930s by a neurologist named Walter Freeman, working in collaboration with a surgeon named James Watts. Freeman would eventually become the public face of the lobotomy in the United States, performing thousands of them over the course of his career, many of them in a form he called the transorbital lobotomy, which used an instrument shaped like an ice pick inserted through the bone above the eye socket and required no operating room at all. Freeman carried out transorbital lobotomies in hospital wards, in clinic offices, in the backs of automobiles. He taught other physicians to perform them in afternoon demonstrations. He believed, or said he believed, that he was offering a quick and scalable treatment for the vast population of severely mentally ill patients who had been warehoused for decades in the state hospital system and for whom no other treatment had worked. The argument in favor of his approach during its peak years in the late 1940s and early 1950s was that anything that reduced the suffering of psychotic patients and allowed them to leave the back wards and return to some semblance of ordinary life was a defensible intervention, even if the cost was a certain flattening of the patient's personality, a certain dulling of the inner life. This was the cultural medicine that Scoville had come up through. By 1948, the state hospital system in Connecticut alone was reporting that more of its inmates had received lobotomies that year than had received dentures, a comparison that feels grotesque now and that was published at the time without apparent embarrassment. The procedure was, for a brief window, a routine instrument of psychiatric care. Scoville was not an outlier in performing it. He was, if anything, a careful practitioner of it, committed to refining the technique rather than industrializing it in the Freeman mode. His fractional lobotomy was specifically designed to preserve more of the patient's personality than Freeman's cruder operation did, by limiting the undercutting to specific regions of the orbital surface of the frontal lobes rather than sweeping indiscriminately across the whole frontal lobe territory. The evidence that his refinement was actually working, in the sense of producing better outcomes for patients, was ambiguous, but the intent was real. What he proposed for Henry was an extension of that refinement into a different region of the brain. In the years leading up to 1953, Scoville had become interested in the medial temporal lobe, in part because of a theoretical literature that was beginning to implicate the limbic structures in both psychotic symptoms and seizure activity. The hippocampus and the surrounding tissues had been identified, in animal studies and in scattered human cases, as structures that could be epileptogenic, meaning that they could generate seizures, and as structures that seemed to be involved in the emotional and motivational disturbances of severe psychiatric illness. The theoretical argument was that if you could remove these structures bilaterally, you might get a therapeutic effect in patients for whom the frontal operation had not been sufficient. Scoville had tried this on about 30 psychiatric patients before Henry, with results that were, as the 1957 paper would later describe them, inconclusive. He had not tried it on a patient with epilepsy. Henry, with his intractable seizures and the theoretical suspicion that the medial temporal structures might be generating them, presented him with what looked from the surgeon's perspective like a reasonable extension of the procedure into a new indication. There is a temptation when telling this story now to make Scoville into a villain. I want to resist that temptation, not because the temptation is without grounds, but because it misses what is actually interesting about the case. Scoville was a competent, respected, intelligent surgeon who had come up inside a medical culture that had, for a decade and a half, been gradually extending the boundaries of what was considered acceptable to do to the human brain in pursuit of therapeutic benefit. He was not operating outside the norms of his field. He was operating at the edge of them, which is a different thing. A villain is someone who chooses to do harm. A surgeon at the edge of the norms of his field is someone who is making a set of reasonable-seeming decisions inside a framework that will later be understood to have been mistaken. The distinction matters because almost all of medicine's historical failures look, in retrospect, more like the second than the first. The lesson of Henry's case is not that Scoville was a bad man. The lesson is that the framework was wrong and that everyone operating inside it, the surgeon, the referring physician, the hospital, the medical culture, shared the mistake. What is harder to absorb is that Scoville himself understood, in the moments that mattered, that he was doing something experimental. The 1957 paper that he would co-author with Brenda Milner 4 years later is unusually frank on this point. It describes Henry's operation as frankly experimental. Those are the exact words. And it acknowledges that the decision to proceed with the full bilateral resection was made despite the fact that no discrete epileptogenic focus had been identified in the intraoperative recordings. There is a particular sentence in the paper toward the end that deserves attention. The authors write that they are publishing their findings partly for their theoretical significance and partly as a warning to others of the risk to memory involved in bilateral surgical lesions of the hippocampal region. Those words, as a warning to others, are the clearest acknowledgement in the record that Scoville and Milner understood what had happened and that they wanted the medical community to understand it too. The paper is, among other things, an act of public retraction. It says, in effect, do not do this again, and the medical community, to its credit, listened. After 1957, bilateral medial temporal lobotomy was not performed on another patient. The procedure ended with Henry. That does not redeem the operation, it does not unremove the tissue, but it places Scoville in a slightly different light from the one in which the popular retellings sometimes place him. The surgeon who later in life campaigned to keep psychosurgery alive, who founded the International Society for Psychiatric Surgery in 1978 and defended the field against what he saw as its premature abandonment, was also the surgeon who, in 1957, stood behind his name on a paper whose central practical message was that his own procedure on Henry Molaison had been a mistake and must not be repeated. Both of those commitments belonged to the same man. He held them at the same time. This is another thing that historical medicine teaches, and that is harder to teach in the simpler narratives. People who do damage are often also the people who publish the evidence of the damage, and the coexistence of those two facts inside a single career is more common than one might expect. The operating room itself, on the morning of the 1st of September 1953, was a place of particular sensory strangeness for the patient. The brain, as was noted earlier, has no pain receptors of its own. The scalp and the skull and the dura, the tough outer membrane that surrounds the brain, are all richly innervated and can feel pain, and the local anesthetic Scoville used was directed specifically at those structures. Once the dura was opened and the surface of the brain was exposed, the tissue below could be touched, stimulated, and even removed, and the patient on the table would feel essentially none of it. This is one of the quietly astonishing facts of neurosurgery, and it is the reason that brain surgery is still often performed with the patient awake. Henry was sedated but conscious. He could answer questions if asked. He could talk, at least in a drowsy way, with the surgical team. He was not in pain. He was, in the most literal sense available, present at the unmaking of his own future, and he did not know it was being unmade, because nothing about the experience felt the way losing everything usually feels. There was no warning sensation. There was no dramatic moment of loss. There was only the quiet work of the suction device passing through tissue that could not feel itself being touched, removing structures whose function neither the surgeon above him nor the patient below him fully understood. If you want to picture what was being removed, place your finger on the skin just in front of your ear, about halfway up, and then imagine pushing inward, past the skull, into the depths of your brain. What lies at the end of that imagined path, on both sides of your head, is the medial surface of the temporal lobe, and tucked within it is the hippocampus itself, a structure shaped, as the early anatomists noted, like a seahorse, curved and small, about the size of a child's little finger. On either side of each hippocampus sit its close neighbors, the amygdala, the entorhinal cortex, the perirenal and parahippocampal regions, a small constellation of structures that, together, form what the literature now calls the medial temporal lobe memory system. Scoville's suction device entered this constellation from the front. It worked its way backward, on both sides, for approximately 8 centimeters. It removed the anterior portions of the hippocampus and the adjacent cortices almost entirely, along with the amygdala, the entorhinal cortex, and substantial parts of the parahippocampal gyrus. It left, as the post-mortem studies more than 50 years later would eventually confirm, about 2 centimeters of the posterior hippocampus on each side, atrophied and largely cut off from its normal inputs, but still, in some histological sense, present. This residual tissue would become important much later in the story. At the time, it was invisible. No imaging technology available in 1953 could show the surgeon, or anyone else, what had actually been removed and what had not. The operation took a few hours. Henry was returned to his hospital room to recover. The seizures, over the months that followed, would in fact diminish, not disappear entirely, but reduce in both frequency and severity enough that Scoville could, by his own lights, count the procedure as a partial success on the dimension for which it had been undertaken. On every other dimension, something had gone deeply wrong, and the wrongness was already present by the time Henry came out of sedation, although it took the hospital staff and his family several days to begin to understand what they were looking at. They noticed first that he could not find his room. He would be escorted back from the bathroom and a few minutes later would have no idea where he had just been. The nurses who were caring for him found that he did not recognize them from one shift to the next. His family, when they came to visit, noticed that he was oddly present in the moment and yet unable to carry anything out of the moment into the next one. A conversation would begin, proceed, and then end. And within a short interval, Henry would have no recollection that the conversation had happened at all, though he would greet the same visitor warmly again, as if for the first time. What had been taken from him was not memory in general. His early life was intact. He could speak fluently about his childhood in Manchester, about the bicycle, about the typewriter factory. His intelligence was intact. His personality was intact. The quiet, affable, slightly shy young man who had arrived for surgery was the same quiet, affable, slightly shy young man who walked out of it by every external measure. What had been taken from him was a specific capacity that, until you see it missing, you do not quite realize you have. The capacity to take an experience and bind it, over the course of a few seconds and minutes, into something that will outlast the experience itself. The capacity to carry yesterday forward. The capacity that, in almost every other case in the medical literature, is so thoroughly taken for granted that no one had ever thought to isolate it as a specific function with a specific neural substrate, because no one had ever seen a case in which it was cleanly absent while everything else continued to work. Scoville realized quickly that something was wrong. The realization did not come in the operating room. It came over the subsequent days and weeks, as the reports from the nursing staff and from Henry's family began to accumulate into a picture that the surgeon could not explain within his theoretical framework. His procedure had been intended to reduce seizures, and it had done that. His procedure had not been intended to produce anything resembling the memory deficit that was now present. He had no good explanation for what he was seeing, and so he did what competent physicians do when confronted with outcomes they cannot explain within their own expertise. He looked outside his expertise. He remembered that at a conference in Chicago the previous year, he had heard a presentation from the Montreal Neurological Institute from a team led by Wilder Penfield about two of their own patients who had developed memory disturbances after unilateral temporal lobe surgeries. He remembered that Penfield's neuropsychologist, a young woman from McGill University named Brenda Milner, had been involved in the careful characterization of those two cases, and he picked up the telephone. Tonight, somewhere in the world, a surgeon is calling a colleague about a case she cannot explain. Somewhere else, a patient is recovering from an operation whose full consequences will become clear only in the weeks to come. The slow and untidy way that medicine actually learns from its outcomes, the phone calls and the conferences and the careful characterization of the unexpected, is running at this moment in every medical culture on Earth. The instrument at the center of that learning, in September of 1953 in Hartford, Connecticut, was a suction device and a young man with quiet Connecticut manners. The learning was about to accelerate because the phone call Scoville was about to make was about to bring to Hartford the one person in the world who, by training and by temperament, was already prepared to see what no one else had yet been able to see. Imagine waking from surgery without knowing quite how long you have been out. The room is slightly unfamiliar, but hospital rooms are always slightly unfamiliar, and the unfamiliarity does not strike you as meaningful. Your mother is nearby. A nurse comes in and checks on you, and you say hello, and she smiles, and she leaves. Sometime later, she comes back. You say hello as if you have not seen her before, because for you, you have not seen her before. She greets you again, patiently, the way nurses greet patients who are still coming out of sedation, and she leaves. Then, a little later, she returns a third time, and you greet her a third time as if for the first time, and the pattern is beginning to be noticeable, to her if not to you, because you do not yet have any way of noticing it yourself. This is what it was like in the days immediately after Henry Molaison's surgery. No dramatic moment of realization, no gasp of horror, only a slow, quiet accumulation of small encounters that did not add up, for everyone around him, into the man he had been a week earlier. The change became legible to the hospital staff before it became legible to Henry. He could not find his way back to his own room from the bathroom. The nurses walked him there and back, and then, within minutes, he would need to be walked again because the corridor no longer belonged to him. He did not recognize the staff who were caring for him. He greeted each shift change as a new introduction. He had, in the technical sense of the term, no difficulty at all with the moment he was in. His conversation was normal. His reasoning was intact. If you sat with him and asked him how he was, he could answer. And if you asked him about his childhood in Manchester or his work at the typewriter factory, He could tell you about it in clear and unhurried detail. What he could not do was carry any part of the current morning forward into the current afternoon. The morning closed behind him as soon as he stopped paying direct attention to it. The afternoon arrived without the morning as its preface. Scoville noticed. His team noticed. The family noticed too when Henry was finally discharged home to Manchester after his recovery, and his mother began to live with him inside the new shape of his condition. Lillian Molaison was by that point in her late 50s, a woman who had already spent 2 decades organizing her household around her son's seizures and had now been handed a different disorder to organize around, one for which she had no training and no useful points of comparison. The seizures, at least, had been legible to her. They came and went. They had an onset and an aftermath. They were a known quantity. This new thing was harder to hold because it did not arrive and then leave. It was simply a property of her son now, constant and silent, and it asked of her a sort of attention she had never had to give before. She had to tell him where things were. This was the first of the daily accommodations, and the one that she would continue to make for the rest of her time with him. The lawnmower lived in a particular corner of the garage. Henry had used it the week before the surgery. He had used it the week after the surgery too, probably, and the week after that, but every time he wanted to use it now, he had to be told where it was because the location had not stayed with him. She would tell him. He would go and find it. He would mow the lawn competently, the way he had always mowed it, because the motor act of mowing was preserved. He would put it back. The next weekend, he would ask again where the lawnmower was, and she would tell him again, and the telling did not bother her, because what else was she going to do? This was her son. 10 months after the surgery, the family moved. Their old house, the one Henry had grown up in, was exchanged for a new one a few blocks away on the same street. The move had been planned before the operation. It went ahead after the operation. And from the day they carried the boxes into the new address, Henry began to live in a house he could never fully learn. He knew that he lived there, in the general way that a person knows where they live, because he had been told and because his things were there and because his mother was there, but he could not learn the address. He could not reliably find his way home from the end of the block. If he walked somewhere on his own, which he was increasingly not allowed to do without supervision, he would arrive at the edge of the neighborhood and then stand there, uncertain, because the map that would ordinarily tell him which way to turn had not been written for this house. It had been written for the old one. The old one was vivid to him. The new one was a rumor that kept needing to be reconfirmed. Inside the new house, he did the same jigsaw puzzle over and over, day after day, without any sense that he had done it before. The pieces were never familiar to him. Each time, the puzzle was a new puzzle, to be assembled fresh. His mother would watch him work on it and then break it up at the end of the evening and put it back in the box, because the next day he would want to start again, and if she had left it whole, he would have been confused by finding it already completed. He read magazines and a week later reread them with the same interest because nothing in them had been retained. He ate lunch and, half an hour afterward, could not say what he had eaten. In one of the small tests that Milner would later describe in print, Brenda sat with him while he ate a full lunch, and then, 30 minutes after the meal ended, asked him to name a single item from what he had just consumed. He could not. He was not even sure that he had eaten lunch at all. The plate had been cleared. The smell of the food was gone. The fact of the meal had disappeared along with everything else. There is a disagreement in the sources about exactly how old Henry was when a bicycle first knocked him down and set his epilepsy in motion. The 1957 paper says 9. Later accounts, drawn from family recollection and from Suzanne Corkin's long work with him at MIT, say 7. I mention the disagreement again here because it is the sort of thing that, inside a case history, one is never quite able to settle. Medical records from the 1930s and 40s were not always written with the precision that a later generation of researchers would wish they had been. Family memories were revised, as family memories always are. And Henry himself, who might ordinarily have been asked to adjudicate, had by the time any of the clarification was being sought, lost the ability to speak about his own biography with the kind of continuous authority that such questions require. His early life was preserved in him, but it was preserved in the form it had taken when the surgery froze it. The details he could offer were the details that had been consolidated by his 10th or 11th year, and those details were not always exact, and there was no mechanism in him for updating them. The measurable facts of his cognition after the operation, once Milner and her team began testing him formally in 1955, are themselves a particular kind of surprise. His intelligence, as measured by the standard Wechsler scale of the period, had actually gone up. Before surgery, he had scored a full-scale IQ of about 104. After surgery, his IQ rose to 112, and in later testing went as high as 117. The improvement showed up particularly in the arithmetic subtests. This was not, the researchers concluded, because the surgery had made him smarter in any meaningful sense. It was because the heavy doses of anticonvulsant medication he had been taking for years before the operation had been sedating him so thoroughly that his pre-surgical performance was depressed, and with the reduction in his seizures after surgery, his medication dose could be reduced, and the reduction in sedation allowed his underlying intelligence to appear more clearly on the tests. The interpretation matters. Henry was not more intelligent after the operation. He was simply, for the first time in a decade, less drugged. The intelligence had been there all along. What was newly absent was the thing everyone had assumed did not need to be named separately. On the formal memory tests from the same period, his score was 67. The gap between an intelligence quotient in the 1-teens and a memory quotient of 67 is an astonishing gap. It is not the sort of thing a single test battery had been designed to produce before, because the two scores were assumed to track together in any brain-damaged patient. A person with an intact intellect was assumed to have an intact memory. A person with poor memory was assumed to have a more generally impaired cognitive profile. Henry's numbers said otherwise. His numbers said that memory and intelligence, whatever they were not the same thing and did not depend on the same structures. Milner would write later that the contrast between his general intelligence and his memory performance was, in her word, striking. It was the kind of striking that changes what a field is able to ask. Until a person presented with that specific dissociation, the field had no clean reason to believe the dissociation existed. The belief arrived through him. He was the instrument. His personality, and this is one of the strange mercies of the case, was also preserved. The young man who had come out of the operating room was, by every family member's account and by every subsequent clinical description, the same quiet, affable, slightly shy person he had been before. He was courteous. He had a mild sense of humor. He was patient with the people around him in a way that made him easy to be with, even though the conversations he could participate in were by their nature shallow, bounded by the 30 or 40 seconds that he could hold a topic in working memory before it slipped away. He did not become irritable. He did not become depressed in any way that was visible on the surface. His mother, asked about him in the early years after the surgery, said that she had seen no change in his personality at all. The 1957 paper uses a phrase, cheerful placidity, to describe his emotional state, and for decades that phrase was taken by researchers and textbook authors as the last word on Henry's inner life. It was not the last word, it was, at most, the top layer. What lay beneath it, and what would be discovered only much later in data that Suzanne Corkin collected, but that was not fully reported during her lifetime, was more complicated. And the complication will have to wait until we are further into his story, because it takes place across decades and has to be approached slowly. For now, in 1953 and 1954 and 1955, What the surface showed was a young man who seemed, to his family and to the first researchers who met him, strangely at peace with a condition that ought by any reasonable standard to have destroyed him. Perhaps he was at peace. Perhaps the 30 or 40 seconds of working memory was long enough to contain a moment but too short to contain a catastrophe. A catastrophe requires, as a precondition, the ability to place the present moment against the remembered backdrop of how things used to be and to feel the drop between them. Henry's drop was not available to him in that form. The backdrop was not accessible on demand. His childhood was there, and his life up to about 1951 or 1952 was there in broad outline, but the specific nearness of what had just been taken from him, the job at the typewriter factory, the capacity to plan for next month, the ordinary confidence of a man in his late 20s that his next year would exist and would be his to shape. That nearness had gone. Without it, the catastrophe had no surface to register against. What remained was the present, and the present, moment by moment, was not actually unpleasant. There was a chair, there was a window, there was a mother in the next room. There was a magazine he was reading with interest, the interest always fresh, because he did not know he had read it before. A life in that condition is not the life one might have chosen, but it is not necessarily a life of continuous suffering either. It is something stranger than that. It is a life composed entirely of presents, stacked one after another, none of them held by the one before, and none of them held onto by the one after. Scoville, watching this unfold from his hospital office in Hartford, did not know what to make of it. His other patients, the psychiatric patients on whom he had performed the same procedure in a more modified form, had also shown memory disturbances, but their disturbances had been obscured by the severity of their underlying psychiatric conditions and had been difficult to characterize cleanly. With Henry, there was no confounding illness. There was only the memory deficit, bright and specific, sitting on top of an otherwise intact mind. Scoville recognized that this was something the field needed to understand. He also recognized more privately that he himself did not have the expertise to characterize it. His training was surgical. The mapping of cognitive function was not what he did, and he had the professional sense to know it. And so, sometime in the months after Henry's operation, he reached out to Montreal, to Wilder Penfield at the Montreal Neurological Institute, whose group had described 2 of their own patients with memory disturbances after unilateral temporal surgery at a conference the previous year. Penfield listened. Penfield passed the request along to his doctoral graduate and colleague, a young woman named Brenda Milner. And Milner, whose background had prepared her for this exact case in a way almost no one else's background had prepared anyone, agreed to travel to Hartford to meet the patient. Tonight, somewhere in the world, a person will go to sleep, and over the course of the night, their brain will perform the slow and largely invisible work of deciding which of today's moments will be carried into tomorrow. Some of today will be strengthened. Some will be allowed to fade. The selection is automatic. It will happen whether or not the sleeper is aware of it. Henry, in 1953 and for the 55 years after, could not perform this selection because the structures that ordinarily run it had been removed. Each of his nights simply ended. In the morning he would wake, and the previous day would not be there to be drawn on, and the present would begin again. For you, as you listen, the work is already beginning to prepare itself. In a few hours, the structures Scoville took from Henry will quietly take today from you and begin to sort it. By morning, parts of what you heard here will still be with you, and parts will be gone. You will not know, until you wake, which parts the sorting chose to keep. This is what it is to have the ordinary equipment. This is what Henry did not have. What does it take as a scientist to recognize the meaning of something the moment you see it? This is a harder question than it looks. The history of science is full of people who sat in front of significant observations and did not know what they were looking at, because the framework for interpreting the observation had not yet been built, or because the person looking was tired or distracted, or trained in the wrong direction, or simply in the wrong mood that afternoon. Brenda Milner's arrival in Hartford, Connecticut in the spring of 1955 is one of the cleanest counterexamples in the 20th century. She came prepared. She had been preparing, without knowing she was preparing, for most of her adult life, and when Henry Molaison was finally placed in front of her, she understood within hours of the first meeting that the young man she was looking at was going to reshape what her discipline could ask. Her path to that moment is worth walking, because it explains the recognition. She had been born in Manchester, in England, in the summer of 1918, into a household of music. Her father, a music critic and journalist, her mother a voice teacher, the two of them both serious and somewhat impractical in the way that musical households tend to be. Brenda had no interest in music. She wanted mathematics. At Newnham College in Cambridge, which she entered on a scholarship in 1936, she set out to become a mathematician and gradually came to the honest conclusion that she was not going to be a great one. She has been generous about this in interviews over the years. She used the phrase ordinary mathematician to describe what she thought she might become, and she did not want to be an ordinary mathematician, and so she transferred, in the quietly consequential way such transfers often happen, into experimental psychology. She finished her undergraduate degree in 1939, the year the war began. The war reshaped everything, including her training. The psychology laboratory at Cambridge was diverted into applied research for the war effort, and for the next 6 years Brenda worked not on the pure questions that had drawn her into the field, but on problems of aircrew selection, radar display design, and the perceptual motor skills of military operators under stress. She learned in the course of that applied work a great deal about how to design a task that would separate out one cognitive function from another. She met Peter Milner, an electrical engineer working on related problems, and married him. When Peter was invited to Canada in 1944 to join a physics research program, the two of them packed up 2 weeks later and left England, and Brenda arrived in Montreal in the middle of a winter she had not been prepared for, with a master's degree from Cambridge in her handbag, and no clear idea what she was going to do with it. She taught for a few years at the Université de Montreal in French because that was the language the job required and she was willing to learn. She began attending seminars at McGill, which was the closer major English language university. In 1947, a psychologist named Donald Hebb returned to McGill and began running a seminar on his manuscript of what would become one of the most influential books in 20th century neuroscience, a book called The Organization of Behavior. Brenda attended the seminar. She found in Hebb the supervisor she had not realized she was looking for, and she eventually persuaded him to take her on as a doctoral student. Hebb, for his part, arranged for her to do her dissertation work at the Montreal Neurological Institute under the broader supervision of the neurosurgeon Wilder Penfield. This was, in retrospect, one of the consequential pairings of her career. Penfield was then at the height of his powers as a brain surgeon, pioneering the technique of operating on conscious epileptic patients under local anesthesia, while stimulating their cortex electrically to map out the functional geography of the brain, 1 millimeter of tissue at a time. Brenda was given access to his patients, both before and after their operations, and was asked to measure what the surgeries had done to their cognition. She earned her doctorate in 1952. By the time she finished, she had already seen in Penfield's clinic more human brains at work and after surgical interruption than almost anyone of her generation. 2 patients, in particular, had begun to trouble her. Penfield referred to them by their initials in the discreet fashion of his time and profession as PB and FC. Both men had undergone unilateral temporal lobe surgery for the relief of severe epilepsy, meaning that the surgeon had operated on only one side of the brain, the side where the seizure activity seemed to originate. Both men had done reasonably well on the seizure dimension of the operation. Both had unexpectedly developed severe memory disturbances afterward. This was not what unilateral temporal surgery was supposed to do. Unilateral operations, by the accepted understanding of the period, were safe procedures. The other hemisphere, still intact, was supposed to compensate for whatever had been removed from the operated side. The fact that PB and FC had emerged with memory impairments anyway was, in the Montreal group's view, probably explicable by the presence of pre-existing and undetected damage on the unoperated side. Damage that was no longer doing its job because the operated side could no longer compensate for it. This was the hypothesis. It was a reasonable hypothesis, and years later, when PB died and came to autopsy, it was vindicated. There had indeed been pre-existing atrophy on the opposite hemisphere. The memory loss had been, in effect, a hidden bilateral condition wearing the disguise of a unilateral one. But the hypothesis, when Brenda and her colleagues first presented the two cases at the American Neurological Association meeting in Chicago in June of 1955, was just a hypothesis. And the presentation, modest in scale, was nonetheless heard by one particular neurosurgeon in the audience who recognized something in the description that matched something he was seeing in his own practice. William Beecher Scoville approached Penfield afterward. He mentioned his own recent case, a young man, not psychotic, operated on bilaterally, presenting with what sounded like the same pattern of memory loss, but in an even cleaner form. He asked if Penfield might send his neuropsychologist down to Hartford to take a look. Penfield returned to Brenda with the question, the way Brenda has told the story many times since. He put it to her simply, whether she would like to go. Her answer, equally simple, was yes. She packed her instruments. The tools of her profession in 1955 were not the brain scanners and eye-tracking systems of a later generation. They were paper, pencils, cards, drawings, puzzles, small physical objects, and carefully designed tests of recognition and recall. A good neuropsychologist of that era travelled with a leather bag of these things, and Brenda's bag contained, among other items, a task that would prove crucial to what was about to happen, although she did not yet know that. The task involved a piece of paper, a pencil, a 5-pointed star with a double outline, and a mirror. It was called the mirror drawing task. She had brought it almost as an afterthought because it was small and portable, and she liked to have a variety of assessments with her whenever she visited a new patient. She would not use it on this first trip, but she had it in her bag, which matters because the bag was going to come back to Hartford more than once. The train from Montreal to Hartford in 1955 took most of a day. It ran down through Vermont and western Massachusetts, across the long fall of landscape that separates the St. Lawrence River from Long Island Sound. And it arrived in Hartford in the evening, with enough time for the traveller to find a room and get some sleep before meeting the patient the following morning. What Brenda saw on that morning, in her own later accounts, was a courteous, slightly slow, friendly young man with a quiet manner. He was 29 years old. He was, by every conventional measure of intelligence and personality, essentially ordinary. He answered her questions clearly. He held sustained eye contact. He laughed politely at the things he was supposed to laugh at. If she had been given the single task of deciding, from a 5-minute conversation, whether there was anything unusual about this young man, she could easily have concluded that there was not. But she was not there for 5 minutes. She was there for several hours, and over those several hours, with the tests she had brought from Montreal, and with the careful, patient observation that her training had built in her, she began to understand what Scoville had been trying to describe over the telephone. The young man could hold a 3-digit number in his mind for several minutes, if she did not distract him. He could recite a pair of unrelated words back to her. His immediate attention, in other words, was intact. But the moment her questions shifted to a new topic, the moment she asked him about something else, and then circled back to the number or the word pair, the information was gone. Not forgotten in the ordinary way, where a trace of effort suggests that something was once there. Gone, in the more complete way, where he did not remember that there had ever been a number or a word pair to hold on to in the first place. She would introduce herself. 20 minutes later, after leaving the room to get a cup of water, she would return, and he would greet her as a new person he had not met before, and she would have to introduce herself again. This happened over the course of that first day many times. Brenda was not surprised, exactly. Penfield's two patients, PB and FC, had prepared her for the general shape of what she was seeing. What was surprising was the purity of it in Henry. In PB and FC, the memory impairment had been tangled up with other effects of the surgery, and the surgery itself had been unilateral, which meant that the full bilateral cost of medial temporal damage had to be inferred from incomplete evidence. In Henry, the surgery had been bilateral by design. The cost, whatever it was going to appear in its undisguised form. And the intelligence that surrounded the cost was not, as with the Montreal patients, complicated by psychiatric illness or by other neurological deficits. Henry was otherwise intact. His intelligence was normal. His personality was normal. His language, reasoning, and perception were normal. The memory deficit sat on top of all of that, like a single, specific, clean subtraction. It was the sort of case that, once a scientist has seen it, makes the relevant theoretical questions available to the field for the first time. Before Henry, memory had been something diffuse, something distributed, something that the dominant American neuropsychologist of the first half of the century, Carl Lashley, had concluded could not be localized to any specific brain region because his experiments on rats had failed to find such a localization. Brenda's own supervisor, Donald Hebb, had gently dissented from Lashley's view in his 1949 book, but the dissent had been theoretical rather than empirical, and the empirical foundation for localizing memory had not yet been built. Henry was going to build it. Brenda was the one who was going to build it with him. She stayed in Hartford for several days on that first visit. She ran the tests she had brought. She watched him interact with the nursing staff, with his mother when Lillian came to the hospital, with Scoville himself. She noted what he could do and what he could not. She began to draft, in the careful prose of the neuropsychological tradition she had inherited from her British training, the descriptions of his deficits that would eventually become the core of a paper. And then she got back on the train and went home to Montreal and began writing, and continued to come back to Hartford at intervals over the following 18 months. The paper she would eventually publish with Scoville in February of 1957 drew on all of those visits. It drew on her tests of Henry and on her tests of 9 other patients, all of them from Scoville's psychiatric practice, all of them operated on with variants of the same medial temporal procedure, all of them presenting with memory impairments of varying severity depending on how far back the surgeon had gone. The paper was the first of her career on this topic. It would become the most cited paper of her career, and one of the most cited papers in the history of her field. But when she boarded the train back to Montreal at the end of that first Hartford visit, she did not yet know that. She knew only that she had seen something she had not seen before, and that she would need to go back. The strange thing about scientific recognition is that it does not usually happen in the moment when the observer first sees the new phenomenon. It happens in the second or third encounter, once the observer has had time to rule out the more ordinary explanations and to confirm that the observation is stable. For Brenda, the stabilizing moment came on the return trip, the second visit, and the third, and all the visits after that, in which Henry continued to greet her as a stranger, no matter how many times she had sat across from him before. This was, by itself, a finding. A normal person who is introduced to a neuropsychologist on Monday and who sees her again on Tuesday will, if asked, report having met her before, even if they cannot remember the specific content of the first meeting. The recognition is automatic. Henry's was absent. He did not recognize her. He did not recognize her on the second visit, or on the 5th, or on the 50th, or on any of the hundreds of visits that would eventually fill the next 30 years of her working life. She would walk into a room. He would look up, He would say hello pleasantly, the way a courteous young man greets a stranger who has just arrived, and she would say hello back and begin again, because there was nothing else to do, and because there was no pretending with him that a relationship of the ordinary sort was possible. Somewhere in the world tonight, a researcher is meeting for the first time the patient who will define the rest of her career. She does not know it yet. She is simply there to run her tests, to take her notes, to think carefully about what she is seeing and what it means. This is what science looks like from the inside most of the time. Not a moment of revelation, but a slow, attentive visit, carried out in an unfamiliar city, with a patient who may or may not become consequential, using instruments that fit inside a bag. What made Brenda's visit to Hartford unusual was not that she arrived prepared to see something extraordinary. It was that she had been, by the long unfolding of her training and her biography, prepared for this exact extraordinary thing. And when it was placed in front of her, she recognized it. The paper is 21 pages long, printed in the close-set, slightly grey typography of mid-century British medical journals, and its title is the kind of plain descriptive phrase that such journals preferred in those years. Loss of recent memory after bilateral hippocampal lesions. It appeared in February of 1957 in the Journal of Neurology, Neurosurgery and Psychiatry, Volume 20, Issue 1, pages 11 through 21. The authors were listed in the order that reflected the convention of the time and the division of labour in the work itself. William Beecher Scoville first, as the surgeon whose operations had produced the patients being described. Brenda Milner second, as the neuropsychologist whose careful testing had characterized what the operations had done. It was not a long paper by modern standards. It did not announce itself. It did not use any of the verbal signaling by which later generations of scientific publication have learned to flag their own importance. It simply described 10 patients, reported what had been done to them and what had resulted, and let the description do its work. The work it did, quietly, was to change what the field of memory research was able to ask for the rest of the 20th century. The structure of the paper was conventional. It opened with a short history of Scoville's surgical program, the 300 fractional lobotomies that had preceded the medial temporal procedures, the theoretical basis for extending the operation into the medial surface of the temporal lobes, the accumulation of 30 cases in which the new variant had been performed. It described, in clean anatomical language, what the surgeon had actually removed from each patient's brain to the best of his ability to reconstruct it from the operative notes and from the post-surgical records. It presented the patients as a series of individual case histories, each with a brief biography, a description of the preoperative condition, a record of the operation, and a summary of the post-operative findings. The 10 patients were then grouped into 3 categories according to the severity of the memory impairment that had followed their surgeries. Group 1, severe memory defect. Group 2, moderate memory defect. Group 3, no memory defect. And the grouping, when you looked at it in the table that Milner had prepared, revealed the pattern that the paper was really about. The severity of the memory loss tracked, with a clarity that was difficult to attribute to coincidence, with the extent of the hippocampal removal. The more hippocampus the surgeon had taken, the worse the resulting amnesia. The patients in whom only the amygdala and the uncus had been removed, without damage to the hippocampus itself, showed no memory defect at all. The single unilateral case showed no lasting impairment either. Memory loss appeared only when the hippocampus and its adjacent gyrus had been damaged bilaterally, and the degree of loss appeared to depend on how much of that structure had been destroyed. Henry was case 1 in the severe category. The paper does not call him Henry. It calls him H.M., the pseudonym that Milner had assigned to him to protect his identity, and that would, for the next 51 years, stand in for his name in every textbook and every journal article that followed. The description of him occupies about 3 pages of the paper, and what is striking about the description, reading it now, is how quiet it is. The writing is flat, careful, almost procedural. It notes his age, his occupation, the history of his seizures, the dates and details of his surgery. It notes in a single unadorned sentence that after the operation he could no longer recognize the hospital staff or find his way to the bathroom. It notes the family's observations about his inability to learn the new address after they moved, his inability to remember where objects in continual use were kept, his habit of doing the same jigsaw puzzles day after day without recognition. It notes the lunch eaten in front of one of the authors, which he could not recall 30 minutes later. None of this is dramatized. None of it is set off with emphasis. The sentences are short and plain, and the effect, when you read them in sequence, is of a very large finding being handed over to the reader with the minimum of rhetorical fuss. This was the British tradition Milner had been trained in. The material was considered capable of speaking for itself. The paper was unusual, however, in one specific respect that deserves attention, because it is the closest thing to a moral statement in the document, and it was placed there deliberately. In the introduction, before describing any of the cases, Scoville and Milner explain why they are publishing. They write that the findings are being reported partly for their theoretical significance, and partly as a warning to others of the risk to memory involved in bilateral surgical lesions of the hippocampal region. Those words, as a warning to others, are the hinge of the document. They are the surgeon and the neuropsychologist, together, signing their names to a public acknowledgement that the procedure described in the pages that followed had produced a result serious enough that other surgeons should not reproduce it. There is no equivalent sentence, that I know of, in the surgical literature of the preceding decade of psychosurgery. The lobotomists of the 1940s had not published in any prominent place a similar admonition about the costs of their work. Scoville and Milner did, and the medical community, reading the paper, took the admonition seriously. Bilateral medial temporal lobe resection was not performed on another patient after 1957. The procedure, as a clinical intervention for epilepsy or for psychiatric illness, ended with Henry. Whatever else one wishes to say about the operation that produced him, the authors of the paper that described him closed the door behind themselves on their way out. The closing of that door is part of what the paper is. What the paper could not do in 1957 was explain why the result had occurred. The authors were clear about this limitation, and the clarity is another mark of the document's honesty. They wrote that the findings pointed to the importance of the hippocampal complex for normal memory function, but they carefully noted that the lesions in their patients had included not only the hippocampus, but also the adjacent hippocampal gyrus, the uncus, and the amygdala, and that with the available evidence, one could not separate the contribution of these different structures to the final deficit. It was the hippocampal complex, as a whole, that seemed to matter. Which specific component within it did the essential work was not a question the paper could answer. That question would occupy the field for the next 30 years. And in some respects, it is still being answered today, as the fine-grained anatomy of the medial temporal memory system continues to be refined with better imaging and better patient characterization. The 1957 paper did not pretend to finish the work. It claimed only to open it. But what the paper did open was enormous. The dominant theoretical framework for memory in American psychology, in the decades preceding Henry's case, had been one of distributed function. Carl Lashley, in a long and influential research program, had attempted to find the neural locus of memory by making lesions of various sizes in various regions of the rat cortex, training the lesioned animals on various tasks, and measuring the degree of memory impairment that resulted. His finding, consistent across many experiments, was that the degree of impairment depended on the total amount of cortex destroyed, not on the specific region that had been destroyed. He summarized this finding with the concept of mass action. The cortex, he argued, functioned as a whole in memory tasks, and any sufficiently large lesion would produce memory deficits regardless of its location. The conclusion drawn from this was that memory was not localized, it was a property of the entire cerebral cortex, or at least of very large portions of it, and looking for a specific brain region that housed memory was, in Lashley's view, a misconceived project. This framework had become the dominant American understanding of memory by the middle of the 20th century. It was the framework Scoville and Milner's paper silently dismantled. Because if memory was truly a distributed function, then removing a small, specific, and deeply buried structure on both sides of a single patient's temporal lobe should not have produced the catastrophic, targeted memory deficit that Henry presented with. The lesion was small by the standards of Lashley's rat experiments. It was localized. And the deficit it had produced was not a diffuse cognitive dulling, but a specific subtraction of one cognitive capacity, leaving the others intact. This was not mass action. This was something else. What the paper argued for implicitly was that memory had a component that depended on the integrity of specific anatomical structures and could be cleanly lost when those structures were damaged. It did not yet argue for everything that would come later. The distinction between different types of memory, the declarative and procedural division that Milner's subsequent work would be central to establishing, had not yet been formulated in 1957. The paper described Henry as having a general deficit of recent memory. It did not yet recognize, because the evidence for it had not yet been gathered, that certain specific kinds of learning were preserved in him alongside the general deficit. That recognition was still 5 years away. What the paper did was establish the initial localization. It placed the hippocampal complex at the center of the memory question. Everything that followed, in the field of memory research for the next 60 years, built on that placement. Henry was not the only patient described in the paper, and it is worth pausing for a moment on this, because the scientific importance of his case has tended, over the decades, to erase the other 9. There was case 2, a 47-year-old physician, identified only as DC, who had undergone a bilateral medial temporal resection combined with orbital undercutting for a paranoid schizophrenic illness, and who had emerged from the surgery with a memory deficit that Milner described as presenting exactly the same pattern as Henry's. He could hold information in his mind for several minutes if undistracted, but the moment his attention shifted, the information was gone. He did not know where he was, he did not recognize the hospital staff, he did not remember that he had had a brain operation. His intelligence, on the Wechsler scale, remained in the superior range, with a full-scale score of 122. Case 3, a 55-year-old former clerical worker identified as MB, presented with similar severity. Cases 4 through 8 showed moderate deficits of varying kinds, always correlated with the extent of hippocampal damage. Case 9, with a removal limited to the uncus and amygdala, showed no memory defect. Case 10, a unilateral operation, also showed no lasting deficit. These 10 lives, summarized in a few pages of a medical journal, constituted the first formal evidence in the scientific literature that the hippocampal complex was specifically required for the normal retention of current experience. Why Henry became the famous one, and not DC or MB, is a question with a straightforward answer, and a more interesting answer underneath it. The straightforward answer is that Henry had no psychiatric illness. His memory deficit sat on top of an otherwise intact mind, in a way that allowed researchers to study it without the confounding effects of schizophrenia or severe depression. He was a clean case, in the technical sense. The other severe patients in the paper had psychiatric conditions that made their deficits harder to characterize. Henry did not. But the more interesting answer is that Henry became famous because Brenda Milner kept visiting him. The scientific significance of a patient is, in practice, a function of continuous attention paid over time. Henry was studied carefully in 1955. He was studied again in 1957 and 1958 and 1960. He was studied across the full length of Milner's career, and then, when she could no longer travel regularly to Boston to see him, across the full length of her student Suzanne Corkin's career after that. Nearly every year of the 55 years Henry lived after his operation, someone was in a room with him, asking him questions and writing down the answers. And that long and patient cumulative record is what made him the most informative amnesic patient in the history of the field. DC and MB were not followed with the same continuity. Their contributions were real, but bounded. Henry's contribution compounded. There is a principle visible in this, and it is one of the more unromantic things science teaches about itself. The significance of an observation in biology and medicine is often not only a function of the quality of the observation, it is also a function of how long the observer is willing to stay in the room. Brenda Milner stayed in the room with Henry for more than 30 years. The accumulated record of her visits, supplemented by the 5 decades of subsequent work that Corkin and others would add, transformed a single striking case into a foundation on which an entire subfield of neuroscience was built. Had she visited him only once and written a single paper, the case would still have been important. It would not have been foundational. The continuity, the patience, the willingness to keep coming back, these were the specifically scientific virtues that Henry's case required and that Milner, by training and temperament, was able to supply. Without them, Henry would be a footnote rather than a chapter in the textbooks. With them, he became the chapter. And the patient himself, across all of those visits, never once recognized the woman who was making the chapter possible. He met her as a stranger each time, and she sat down across from him each time, and they began again. This was the working relationship that underlay the science. It was tender. It was one-sided. And it was, in a way that the paper itself could not fully convey, the ground on which everything else stood. By the end of the 1950s, the community of researchers interested in memory had begun to absorb what Scoville and Milner's paper was telling them. Animal studies of hippocampal lesions, which had been inconsistent in their findings during the earlier part of the decade, began to be reinterpreted in light of the human evidence. Other amnesic patients, whose memory deficits had been described in scattered case reports without clear anatomical correlation, began to be re-examined for evidence of hippocampal involvement. The concept of a medial temporal memory system as a specific neural substrate for the encoding of new declarative information started to coalesce. And as all of this was happening in the published literature, Milner was continuing to visit Henry with the small leather bag of tests she had first brought to Hartford in 1955, and she was about to put something new into the bag, an assessment she had considered previously but not yet used, that would, within a few years, disclose a second and entirely unexpected dimension of his condition. That dimension would require the field to revise, yet again, what memory was. But the disclosure would come through the same unremarkable materials that Milner's work always required: a piece of paper, a pencil, a shape to be copied, and a mirror through which the patient would have to see what his hand was doing because the direct view would be blocked. The test was going to take 3 days, and on the 3rd day, Henry was going to do something that the theory of memory that Scoville and Milner's 1957 paper had just established would not, in its current form, be able to explain. Right now, if you are listening carefully, the same structures in your own temporal lobes that Milner was beginning to understand in 1957 are doing their quiet work on the sentences you are hearing. You are holding the paragraphs together. You are linking them to what came before. The fact that the holding is happening at all, that memory has a seat in the body and can be found if you know where to look. This is not a piece of knowledge that humans have always had. It is knowledge that began, in its modern form, in the winter and spring of 1955, in a hospital in Hartford, Connecticut, through the careful work of a 36-year-old neuropsychologist and a 29-year-old man who had agreed to help her with her tests. Tonight, as you drift towards sleep, the structures that Henry no longer had will sort what you heard here into a form that some of it will survive into tomorrow. The sorting is the ordinary miracle. Henry is the reason we know to call it a miracle at all. In 1962, Brenda Milner sat down across from Henry Molaison with a piece of paper, a pencil, and a mirror. She had been visiting him for 7 years by that point. She had been his principal examiner since his second year of follow-up. She had written the paper that had placed him at the center of the memory literature, and she had continued to test him, visit by visit, as the question of what memory was had begun to open up in her field. What she brought to the table on this particular day was a task she had not previously used with him, though the task itself was not new to psychology. Variants of mirror drawing had been in the experimental literature since at least the turn of the century. The novelty was not the task. The novelty was the patient on whom it was about to be used. She placed the paper in front of him. On the paper was a shape, a 5-pointed star, drawn with a double outline, so that what he would be tracing was not a single line, but the narrow channel between two concentric stars, a kind of track running along the edges of the star's form. She gave him the pencil, and she set up the mirror in such a way that Henry could see his own hand and the pencil in it only by looking into the mirror rather than at the paper directly. A small screen, or the angle of the arrangement itself, blocked the direct view. To complete the task, he would have to coordinate his hand with what he saw reflected rather than with what would normally be in front of him. For anyone who has not tried this, the difficulty is immediate and surprising. The visual and motor systems of the healthy brain are tuned across years of ordinary use to the correspondence between the position of the hand in space and the image of the hand on the retina. When that correspondence is suddenly flipped by a mirror, the hand wants to go one way, and the visual feedback says go the other way, and for the first several trials the tracing is clumsy and full of errors. The pencil keeps veering out of the track. The hand keeps making corrections that, because they are based on the mirrored image, turn out to be the wrong corrections, which then have to be corrected again. It is difficult. It is also, with practice, learnable. A healthy subject, given 10 trials on a single day, will improve measurably. Given 3 days of practice, most healthy subjects become quite good at it. Milner explained the task to Henry and asked him to begin. He tried. On the first trial, he made about 30 errors, where an error was defined as any moment when the pencil strayed outside the double outline of the star. The first trial took him quite a while, because every deviation had to be corrected, and the corrections kept producing further deviations. By the second trial, he was a little better, about 20 errors. By the 10th trial of that first day, he was down to 5 or 6. His performance on day 1, in other words, traced a learning curve of the kind that any neuropsychologist would recognize from a healthy subject. He was getting better at the task. Something was being acquired over the course of the trials that had not been there at the beginning. Milner watched this with what must have been a steadily rising degree of interest, though she is characteristically modest in her later descriptions of the moment. What made the learning curve remarkable was not the shape of the curve itself, which was ordinary. What made it remarkable was the patient who was producing it. Between trials, Milner would set the task aside briefly, perhaps to record the error count, perhaps to ask him a question, perhaps simply to let him rest. And each time she returned to the task, Henry had no memory that the task had been going on. She would have to explain it to him again. The mirror, the star, the double outline, the rule that the pencil should stay inside the track. He would listen with the polite attention of a patient who was encountering the instructions for the first time. He would pick up the pencil, and then, without being told, He would perform the task at the level his hand had reached on the preceding trial. The error count would be low, the coordination would be improved, the clumsiness of the first attempt would not return. His hand had learned something that his conscious, declarative mind had no access to at all. On the second day, Milner came back. She brought the paper, the pencil, the mirror. Henry greeted her as a stranger, as he always did. She explained what they were going to do, as she always did, and he accepted the explanation with the courtesy of someone receiving it for the first time. He began the first trial of day 2. He made about 10 or 12 errors, already better than his end of day 1 performance. By the later trials of the second day, the error count was down further, and he was moving the pencil through the track with a fluidity that had not been visible in the previous session. He was, in every measurable sense, consolidating the skill. Something in his brain was carrying the improvement of day 1 forward into day 2, and then forward again from trial to trial within day 2, and using the accumulating practice to refine the motor performance. But nothing in his conscious experience of the testing was carrying anything forward. Each trial began, for Henry, as a new and unfamiliar encounter with a slightly strange task. On the third day, the same thing happened again. The error count dropped further. By the end of the third day, Henry was tracing the star cleanly, almost without deviation, at a level of competence that would have passed for proficient in any healthy subject practicing the same task for 3 days. And then, at the end of that third day, Milner showed him the drawings he had just produced and asked him what he thought. He looked at them. He considered them for a moment, and then, in words that Milner has described many times in the decades since, he made a small and astonished comment to the effect that he seemed to have done rather better at the task than he had expected. Not better than he remembered doing because he did not remember doing it at all. Better than he had thought he would do as he looked at the evidence of his own hand's work, sitting in front of him on the paper. The comment is unassuming. The comment is probably the single most consequential thing any patient has ever said to a neuropsychologist in the history of the field. Because what Henry was looking at, without knowing it, was the physical trace of a learning process that had happened inside him over the course of 72 hours, and that he had no conscious access to whatsoever. His hand knew. He did not. Milner sat with this. She did not, to her credit, rush into an immediate theoretical pronouncement. What she did was recognize that she had just observed something that the current theory of memory, including the theory she herself had helped to establish with the 1957 paper, could not account for. The 1957 paper had treated Henry's deficit as a general impairment of recent memory. It had assumed, in line with the theoretical framework of the time, that memory was essentially one thing, and that what had been damaged in Henry was the capacity to form new memories as a single general ability. The mirror drawing result said that this could not be right. Henry had formed something new over the course of the 3-day task. He had done it without the participation of whatever cognitive apparatus usually generated the conscious recollection of having done it. The conclusion, which Milner would articulate in a paper published that same year in a French neuroscience volume edited by Passois, was that there must be at least 2 kinds of memory, depending on different brain systems. One kind, the kind damaged in Henry, was the memory for events and facts that could be consciously recalled and reported. The other kind, the kind preserved in him, was the memory for skills and procedures, which could accumulate with practice without any accompanying awareness of having practiced. These 2 kinds of memory appeared to be separable. They had to be separable, because in Henry they had come apart. This conclusion was, at the time, extraordinary. Memory had been treated, in the psychology of the first half of the 20th century, as a fundamentally unitary phenomenon. The word memory had referred, more or less, to a single capacity that might vary in degree from person to person and from moment to moment, but that operated, at its core, on the same principles. What Henry demonstrated was that this picture was wrong, or at least drastically incomplete. Inside the single-word memory, there were at least two functionally distinct systems, built out of different neural structures, governed by different rules. One of them depended on the medial temporal lobe, and when the medial temporal lobe was damaged bilaterally, as in Henry, that system failed. The other did not depend on the medial temporal lobe. It lived somewhere else. And wherever it lived, Milner did not yet know, but would eventually be part of the long effort to figure out, the somewhere else had been spared by Scoville's operation. The hand had kept its teachers. The somewhere else, as the field would come to understand over the next several decades, turned out to be distributed across several different brain regions, depending on the specific kind of skill being learned. Motor skills of the kind that mirror drawing required, the slow refinement of a perceptual motor coordination through repeated practice, depend heavily on the cerebellum and on the basal ganglia, two structures deep in the brain that had not been touched by Scoville's surgery. The cerebellum, at the back of the brainstem, is a structure of extraordinary computational density, containing more neurons than all of the rest of the brain combined, and it is the principal orchestrator of the fine timing of motor acts. The basal ganglia, clustered around the thalamus in the center of the brain, are involved in the gradual learning of action patterns through reinforcement, the kind of learning that accumulates when the same action is repeated over and over and the nervous system adjusts it, small increment by small increment, toward greater efficiency. Henry had both of these structures entirely intact. When his hand traced the star across the 72 hours of the mirror drawing task, the cerebellum and the basal ganglia were doing what they had always done, adjusting, refining, consolidating. The work of those structures did not pass through the hippocampus. It did not need to. It had its own pathways, its own rules, and its own timescales of consolidation. The hippocampus, as the 1957 paper had begun to establish, was required for the conscious, declarative, reportable form of memory. The implicit, procedural, unreportable form of memory ran on a different set of tracks. This distinction, as Milner first saw it in 1962, would be refined over the following decades into what is now called, in the textbooks, the distinction between declarative and non-declarative memory. Declarative memory, sometimes also called explicit memory, refers to the conscious, reportable knowledge of facts and events, the kind of memory that Henry had lost. Non-declarative memory, sometimes called implicit, refers to a broader collection of capacities that change with experience but do not require conscious recollection to express themselves. It includes skill learning. It includes priming, the phenomenon by which a prior exposure to a stimulus makes the subsequent recognition of that stimulus faster even when the person does not remember the prior exposure. It includes classical conditioning, the slow acquisition of automatic responses through repeated pairings. It includes habit in the technical sense. All of these systems, in varying degrees, were preserved in Henry. All of them continued to function normally across the 55 years of his post-operative life, even as the declarative system that would ordinarily have bound them together into a conscious autobiography had gone silent. His hand learned mirror drawing in 1962. It did not forget. When Milner or her successors would bring the task back to him years later, his performance was better than a naive subject would have shown on their first attempt. The skill had persisted, silently, in the part of him that did not need to be told that it had learned. There is something worth sitting with here because it is strange in a way that the technical language of the textbooks tends to smooth over. When Henry looked at his third-day drawings and remarked that he had done better than he had expected, he was in a real sense meeting his own body for the first time. His hand had been practicing without his permission. His hand had improved without his knowledge. And the hand and the conscious person to whom the hand belonged had, over the course of 3 days, come to occupy slightly different relationships to the task. One of them knew how to do it. The other had no idea it could be done. This division is not, as it turns out, unique to Henry. It is simply more visible in him than in the rest of us, because in healthy people, the two systems cooperate so smoothly that the cooperation itself becomes invisible. Most of what you know how to do without being able to articulate how. The movements by which you type, the fine adjustments by which you maintain balance while walking, the way your hand finds the right key in your pocket without your having to look. These are all procedural knowledge, carried by the cerebellum and the basal ganglia, and the network of motor cortices that interact with them. And the declarative awareness of these abilities runs alongside them without usually being required to explain them. If you had to describe, in words, exactly what your fingers do when you tie a shoelace, you would find the description surprisingly hard to produce. The knowledge is in the fingers. The fingers have not learned it in a form that the declarative system has easy access to. Right now, as you listen, your procedural memory systems are doing a substantial amount of the work that keeps you upright in your chair or your bed. The orientation of your spine, the slight tension in the muscles of your neck, the particular way your eyelids are beginning, perhaps, to feel heavier than they were when the chapter began. Your cerebellum is managing all of this in the background without consulting the declarative part of you that would recognize, if asked, that you are a person with a name and a history listening to a particular sleep documentary. The two systems are running in parallel as they always do, and the parallelism is the ordinary condition of being awake in a body. Tonight, when you sleep, both systems will be active in different ways. Your declarative memory will process the events of the day, selecting, editing, consolidating the record of what you did and said and saw, while your procedural memory will refine the skills your body has been practicing, strengthening the motor patterns that were exercised during the day and letting the unused ones rest. By morning, the two kinds of consolidation will have worked independently through the night, and you will wake into a body whose skills have been quietly polished and a mind whose record of yesterday has been quietly curated. Henry, through all the 55 years after his operation, had only the second kind of consolidation available to him. The first had been taken, the second remained, and the second, on its own, was enough for him to learn to trace a star in a mirror without ever knowing that he had. The structures that Scoville removed from Henry Molaison on the 1st of September 1953 occupy less volume than a pair of walnuts. Taken together, their combined tissue on both sides of the brain comes out to roughly the mass of a large strawberry. You could hold the whole of what was taken in the palm of one hand without noticing any particular weight. And yet, this small amount of tissue, distributed across a handful of interconnected regions on the inner surface of the temporal lobes, turned out to be the physical substrate for the capacity by which a human being converts the flow of experience into a durable record. Remove it bilaterally, as Scoville did, and the flow continues. The experience arrives, moment by moment, with no obvious disturbance at the surface, but nothing is retained. The record-making machinery is gone. What remains is the experiencing. The remembering has ended. To understand what was lost, it helps to walk through the anatomy slowly, because the anatomy is not a single structure, but a small network of structures that work together, and the work they do is distributed across them in ways that still, more than 60 years after Henry's operation, are being refined in the research literature. The walk begins on the inner surface of each temporal lobe, tucked down where the temporal lobe curves inward toward the midline of the brain. If you could somehow see into your own head, looking from below and from the inside out, you would find, on each side, a curved band of cortex running forward to back along the edge of the temporal lobe. This band contains, in sequence from front to back, several regions that the anatomists have given separate names, and that together constitute the principal input and output structures for the hippocampus itself. At the front end of the band sits the entorhinal cortex, which functions as the main gateway. the place where information coming in from the rest of the brain's cortex is funneled toward the hippocampus, and from which the hippocampus's processed output is sent back out to the cortex for long-term storage. Just in front of the entorhinal, on either side of it, sit the perirhinal cortex and the parahippocampal cortex, two regions that handle different kinds of incoming information. The perirhinal tends to deal with information about individual objects, their identity, their familiarity, their recognition. The parahippocampal tends to deal with information about contexts and scenes, the layout of a room, the arrangement of objects within a landscape, the spatial structure that frames the objects within it. Together, these three cortical regions constitute what the literature calls the parahippocampal region. They are the reception area for the hippocampus. They pre-process and organize the information that the hippocampus will then work on. The hippocampus itself sits just medial to these cortical inputs, curved and elongated, running forward to back along the inner surface of each temporal lobe. Its shape is strikingly regular. Viewed in cross-section, it shows a characteristic interlocking pattern of two curved layers of cells, one folded inside the other, which the early anatomists compared to a seahorse, and which the 19th century anatomist Orontius named in Latin after that comparison. Hippocampus is the Greek word for seahorse, and the name stuck because the resemblance is genuinely striking when you see the structure in a well-prepared specimen. The two interlocking layers go by the names dentate gyrus and cornu ammonis. The cornu ammonis, Ammon's horn, named for an Egyptian deity whose ram horn iconography the structure was thought to resemble, is further subdivided into four subfields, labelled CA1 through CA4, each with slightly different cell types and slightly different roles in the computations the hippocampus performs. Near the back end of the hippocampus, where it curves upward and merges with a neighbouring structure called the subiculum, information flows out toward the rest of the brain via a large white matter bundle called the fornix. The fornix arches upward and forward, carrying the hippocampus's output to several distant targets, including the mammillary bodies at the base of the hypothalamus and, through relays, the thalamus and the frontal cortex. If all of this anatomical detail begins to blur together in the hearing, that is, in part, the point. The medial temporal lobe memory system is not one structure. It is a small constellation of tightly interconnected structures, each doing a slightly different job, and the complete picture is one in which information flows into the parahippocampal region from the cortical sensory and association areas, is organized and pre-processed there, is passed into the entorhinal cortex, is fed from the entorhinal into the hippocampus through a specific set of projections, is worked on within the hippocampus's folded layers, and is eventually returned back out through the entorhinal cortex, across the parahippocampal region, and into the distributed cortical networks where it will, if all goes well, become a persistent memory. The whole loop runs in both directions, many times, as information is encoded and consolidated. It is an elegant piece of wiring. It evolved over hundreds of millions of years. And Scoville, on that September morning in 1953, removed most of it from both sides of Henry's brain. What was left, as the 2014 post-mortem examination of Henry's brain by Jacopo Annese and his colleagues eventually confirmed, was less complete than the original 1957 paper had implied, but also less empty than the simpler textbook accounts have sometimes suggested. On the left side, Annese's team found about 24 millimeters of the posterior hippocampus still present, preserved at the back of the structure where Scoville's suction device had not reached. On the right side, they found a similar remnant, roughly the same length. Some of the entorhinal cortex had been spared. A small strip of the perirhinal cortex was still there. The posterior portion of the parahippocampal gyrus was largely intact on both sides. What had been removed, in summary, was the front 2/3 or so of the hippocampus on each side, along with most of the entorhinal cortex and substantial parts of the surrounding cortical input regions. What had been spared was the back portion of the hippocampus and a thin rim of the surrounding cortex. The tissue that remained was, in a literal sense, still there. But its connections to the rest of the brain had been severely compromised because the cortical input pathways that would normally have fed it had themselves been removed, and the output pathways through the fornix had been disrupted as well. The residual hippocampus was a structure without a working input line and without a normal output line. It was an island, and an island that cannot send or receive is not performing the function that the healthy structure performs, even if its cells are still metabolically alive. This subtlety about the functional status of the residual tissue matters for how the case has been interpreted. For several decades after the 1957 paper, Henry was described in the literature as having suffered a complete bilateral medial temporal resection. The subsequent imaging studies of the 1990s, using the magnetic resonance scanners that by then had become available, complicated that picture somewhat by showing that the hippocampal tissue had not been entirely removed. The 2014 post-mortem refined it further by showing exactly how much remained and where. The revised picture did not overturn the central finding. The memory loss was real, the medial temporal system was central to memory, the principal conclusions of the 1957 paper remain intact. But it did make the interpretation of Henry's specific pattern of deficits more careful. Some of the subtle sparing in his semantic memory, which would later become a subject of scientific interest, may have been enabled by the residual tissue. Some of it may have been enabled by cortical structures outside the medial temporal system entirely. The case is not quite as clean in its anatomical underpinnings as the earlier accounts suggested. Henry was not a pure hippocampal amnesic. He was something closer to a patient with nearly complete bilateral medial temporal damage, plus a small amount of anatomically residual but functionally compromised tissue. The distinction is technical. It is also real, and it will become relevant when we look at the specific islands of preserved knowledge that his case eventually revealed. What the medial temporal lobe memory system does when it is working normally is bind together the information coming in from the rest of the cortex into a form that can be consolidated for long-term storage. Imagine, for a moment, the ordinary experience of meeting someone new at a social gathering. You see their face, you hear their name, you notice what they are wearing, what they are holding, the general layout of the room you are standing in, the music playing in the background. All of this arrives at your brain through different sensory pathways and is processed initially in different cortical regions. The face goes through visual cortical areas specialized for face recognition. The name goes through auditory and language areas. The room layout is handled in spatial and visual networks. The background music passes through auditory processing streams. The full experience of meeting this person is, at the level of cortical activity, a distributed event, happening across many separate brain regions simultaneously. What the medial temporal memory system does is take this distributed event and bind it into a single associated record. The face, the name, the room, the clothing, the music, all of it is linked together by hippocampal and surrounding activity in such a way that a day or a week later, when you encounter one element of that original event, the others can be retrieved with it. You see the face again and the name comes back. You hear the music again and you remember where you heard it. The binding is what the hippocampus does. The binding is what Henry had lost. Without that binding, the elements of an experience arrive in Henry's cortex and are processed normally, moment by moment, but they do not get tied together into a durable associated record. The face arrives and is processed. The name is heard and is understood. The room is perceived and its layout is registered in working memory. But the next time Henry encountered any one of these elements in isolation, the others did not come with it. There was no associated retrieval, because there had been no associated encoding. Each element returned to him, if it returned at all, as a freestanding fragment, detached from the context in which he had first experienced it. Most of the time, it did not return at all. The working memory trace, held briefly by cortical circuits for the duration of the original encounter, simply faded when his attention moved on, and the permanent consolidation that would have required the medial temporal system did not occur. The experience happened, the experience was lived, and then the experience was released, without being kept. There is, at the center of all of this, a question that the neuroscience can map but cannot answer. If you can map the structures that perform the binding, and you can describe the computational function they carry out, and you can show what happens in the patient when that function is disrupted, have you explained memory, or have you only explained the mechanism by which something else, which we have not yet explained, is made possible? The question is an old one. It appears in various forms throughout the literature of consciousness studies. It has been given names and frameworks and formal articulations, but the question at its core is straightforward. Something happens in the hippocampus when you remember meeting someone at a party last week. Electrical and chemical events occur. Specific circuits fire in specific patterns. All of this is, in principle, observable from the outside. What is not observable from the outside is the felt quality of the remembering. The sense when you bring the memory to mind that you are there again, that you can almost see the room, almost hear the music, almost recall the small pressure of the handshake. The mechanism is in the brain, the felt quality is in the experience. And the relationship between the two, between the public fact of the neural event and the private fact of the remembered moment, is the one thing that no amount of further neuroscience, however refined, has yet been able to close. Henry's case makes this gap unusually visible. When the mechanism was disrupted in him, the felt quality disappeared along with it. The face he had just seen did not later return with the room he had seen it in. The meal he had just eaten did not remain as a remembered meal. The mechanism had been taken, and the phenomenal experience of remembering had followed it out of his life. This is evidence that the mechanism is required for the experience. It is not evidence that the mechanism is the experience. What was it like for Henry, moment by moment, across the 55 years in which the mechanism was not there to support the binding of his ongoing experience into a remembered record? The question cannot be answered from the outside. It can only be guessed at. From his occasional comments recorded across decades of testing, there are suggestions that he had some awareness of his own condition without being able to place that awareness in the framework of a continuous life. He would sometimes say, in response to a question about the future, that he did not know what would happen tomorrow, because he did not really know what would happen in the next 5 minutes. He would sometimes, when a new task was introduced, look slightly anxious, as if aware that something had just changed, but unable to specify what. The inner experience was not flat. It was not empty. What it was, exactly, we cannot say. The person who could have said is no longer available to say it, and was never, during his life, quite able to describe it in terms that fully reach the outside. This is the philosophical problem at the heart of memory research, and Henry's case sharpens it in a way that few other cases have. The neural machinery of remembering can be identified, studied, imaged, damaged, and reproduced across patients. The felt quality of remembering can be reported on from the inside by anyone who still has it. What no methodology has been able to do is show from the outside that the neural machinery is the felt quality rather than the substrate that supports it. The medial temporal lobe memory system in Henry had been largely removed. The felt quality of remembering in Henry had largely gone. The correlation is tight. The explanation for the correlation remains open. What makes the correlation work is not known. It may not be knowable, at least not by any method the current neurosciences possess. This does not mean the question is empty. It means the question is genuinely unresolved, and that the distance between the mechanism and the experience, which Henry's case brings into unusually clean view, is one of the open frontiers of the science. Somewhere inside your own skull, right now, the system that Henry lost is doing the quiet work of binding the current moment to the moments that preceded it. The structures are small, the work is continuous, and most of the time, for most people, the work is entirely invisible, because the only evidence of its operation is the fact that your experience hangs together into a continuous life. You are not currently experiencing your memory as a distinct event. You are experiencing it as the background against which everything else appears to make sense. Henry did not have that background. What the world was like for him, in the presence of its absence, is the one thing about his case that the science, for all of what it has accomplished, cannot tell us. In 1966, a 29-year-old researcher named Suzanne Corkin took a train from Montreal to Hartford, Connecticut, to begin working with Henry Molaison on her own. She had met him 4 years earlier, in 1962, as a doctoral student of Brenda Milner's at McGill, and she had come to him already knowing who he was. She had grown up in Hartford itself, the daughter of a local family, and when she first heard about the famous amnesic patient at her advisor's institute, there was a small echo in her of home. The patient was from her city. The surgeon who had operated on him had worked at the hospital she had known as a girl. There was something in the coincidence that drew her attention. When Milner began sending her students down to Hartford to assist with the testing, Corkin was one of the first to go. By 1962, she had met Henry. By 1964, she had finished her doctorate with Milner as her supervisor. And by 1966, she had moved to Boston to take up a position at the Massachusetts Institute of Technology, where she would spend the rest of her career. One of the first things she did at MIT was to begin the quiet, logistical work of bringing Henry up from Hartford to Cambridge for more extended testing. Milner continued to visit him in Connecticut for a few more years, but the operational center of Henry's scientific life was, by the late 1960s, shifting to MIT. And the person at the center of it was now Suzanne Corkin. What began in 1966 and did not end until Henry's death in 2008 was a working relationship that occupies an unusual position in the history of science. Corkin was, in formal terms, the principal investigator on the MIT Clinical Research Center's long-running study of Henry. Across 42 years, she oversaw the scheduling of his visits, the design of the experiments he was enrolled in, the liaison with the many other researchers who wanted access to him, and the stewardship of the voluminous data that the work produced. She was, in practical terms, the person who made the continuation of the science possible. Without her, the follow-up that the 1957 paper had implicitly called for would have ended after Milner's own visits tapered off. With her, it extended across 4 additional decades, and the cumulative depth of what is now known about Henry's condition is largely a function of that extension. More than 500 individual studies drew on testing sessions she had arranged. More than 100 researchers from institutions around the world had access to him because Corkin's laboratory at MIT had built and maintained the infrastructure that allowed such access. In the scientific sense, she was the hinge around which the rest of Henry's scientific life swung. But there was a second relationship running alongside the professional one, and it is the second relationship that makes the case unusual. Because Henry did not recognize her. He did not recognize her on the day in 1962 when they first met. He did not recognize her on the day in 1966 when she began her own principal investigation. He did not recognize her on any of the roughly 300 occasions over the next 42 years when she walked into a testing room and sat down across from him. Every visit for him was a first meeting. Every explanation of the task he was about to do was, from his side of the table, a fresh explanation of an entirely new activity. Every courteous greeting, every polite acknowledgement, every moment of his gentle and slightly shy attention to her. all of it was offered as though to a stranger because from his point of view that was what she was. The relationship that was developing on her side, through hundreds of hours of shared time, simply did not develop on his side. It could not. The mechanism that would have allowed it to develop had been taken from him in 1953. There is a particular sort of tenderness that is required to keep showing up to a relationship that will, by its nature, remain one-sided, and Corkin was, by all accounts, capable of it. She did not pretend the asymmetry was not there. She did not compensate for it by treating Henry as a laboratory subject stripped of his personhood. She did the opposite. She learned, across the decades, what he liked and what he did not like, what made him laugh, what made him anxious, what sorts of tasks he found pleasant and what sorts he found tiring. She coordinated the pace of his testing sessions around his stamina. She brought him snacks he enjoyed. She talked to him between tasks the way she would have talked to anyone else, and when he told her something he had already told her many times before, a story from his childhood, a remark about his mother, an observation about the weather outside the window. She listened with the kind of attention that did not betray that she had heard it before, because for him she had not. She was, in an unusual sense, building a relationship that only she could remember. He was the other person in it. The memory of it lived entirely in her alone. By 1980, Henry's living situation had changed. His mother, Lillian, who had been his primary caregiver for the nearly 3 decades since the surgery, had grown old, and her own health had begun to deteriorate in ways that made home care for Henry no longer feasible. A distant cousin on his mother's side, a woman named Lillian Herrick, had been assisting with his care, and when her own health failed, the care arrangement had to be formalized. Henry was moved in 1980 to the Bickford Health Care Center in Windsor Locks, Connecticut, a nursing home founded by the brother of the cousin who had been looking after him. Bickford was a quiet facility on the outskirts of a small Connecticut town. It housed around 48 residents. It was one of the earliest facilities in the state to adopt a model of elder care known as the Eden Alternative, which emphasized the presence of plants, animals, and intergenerational interaction as therapeutic, rather than decorative elements in the daily life of the residents. There were cats at Bickford. There were several birds in aviaries near the common rooms. There was a rabbit that sometimes sat on the laps of residents in the courtyard. There was a dog named Sada, a gentle animal who wandered the halls and accompanied residents on walks. For the last 28 years of his life, this was where Henry lived. His room was number 133 on the far side of the building. From his window, he could see, several times a day, Amtrak trains pass along the tracks that ran through Windsor Locks. Across the tracks stood the abandoned red brick shell of an old paper mill, which had closed decades earlier and which stood week after week in the same disused condition, slowly being reclaimed by weather and ivy. Henry liked watching the trains. Every pass was a new pass for him because he could not retain the memory of the previous one, and so the trains arrived for him always for the first time, each as unexpected as the first he had ever seen. He would sit in his wheelchair by the window, sometimes with the rabbit on his lap, sometimes with Sade at his feet, and he would watch the trains go by. The paper mill across the tracks was the visual constant against which the moving trains gave him, again and again, a small experience of something happening in the world. It is a strange detail to sit with, because the detail is so domestic, and because the experience of watching a train pass a window is, for anyone else, one of the most ordinary experiences available. For Henry, the ordinariness was also the novelty. Every train was his first train, every paper mill was his first paper mill, until he looked away and the whole scene was released. He did crossword puzzles by the hour. This was probably his principal entertainment across the last 3 decades of his life. He liked them particularly, and he was good at them, because the knowledge required for crosswords was precisely the knowledge he had preserved. The semantic knowledge of words, the general knowledge of the world up to 1953, the sense of how language and clues fit together, that does not depend on the episodic memory of having seen a particular crossword before. He could do the same puzzle several days in a row and find it interesting each time because for him it was always a new puzzle. When he found a standard crossword too difficult in his later years, he moved to simpler find-a-word puzzles, which require only pattern recognition rather than general knowledge. He was patient with them. The researchers who observed him at Bickford noted that he would work through a book of such puzzles methodically, making small marks with his pencil, and that he took evident satisfaction in completing each one. Even though the satisfaction did not persist past his next distraction, he watched television. His favourite programme, the one that researchers and staff at Bickford both noted he returned to with consistent interest, was the 1970s sitcom All in the Family. He had first encountered the show during the years when it was originally airing in the early to middle 1970s, which was well after his surgery. By the normal rules of his condition, the characters of that show should not have become familiar to him. He should not have known who Archie Bunker was. He should not have known what Archie Bunker called his son-in-law, the nickname Meathead, used as a running comic device across the show's run. And yet he did know. Ask him about Archie Bunker, and he would say something about him. Mention Meathead, and he would connect the word to the show. This should not have been possible, given the standard picture of his condition. And yet it was true. Corkin and her colleagues documented it carefully, and the documentation of it became one of the small anomalies that would eventually, over the course of the 46 years of her work with him, accumulate into a more complicated picture of what Henry's damaged memory system could and could not do. We will come back to the anomalies. For now, the point is simply that Henry, across the last 28 years of his life, watched a television sitcom about a working-class American family in Queens, and that the sitcom became, in some partial and imperfect way, a presence in his mind that the standard account of his condition had not predicted. Corkin arranged, several times a year, for him to be brought up from Bickford to the MIT Clinical Research Centre in Cambridge. He would come for stretches of up to a month at a time. He would live in the research centre, which provided accommodations for long-term study subjects, and during the stays he would participate in whatever experiments the laboratory was running. The experiments ranged widely. There were straightforward memory tests, variants of the assessments Milner had used in the 1950s and 1960s, now rerun to track the stability of his condition over decades. There were newer tests designed to probe specific subtypes of memory that had been identified in the intervening years, tests of priming, of classical conditioning, of various kinds of implicit learning. There were studies of his spatial navigation, which attempted to characterize exactly what he could and could not learn about the layouts of places he visited. There were studies of his language processing, his perceptual abilities, his emotional responses. There were, more controversially in later retellings, studies of his pain tolerance and his physiological responses to various stimuli. Across the decades, the sheer range of what was asked of him was large. He accepted it all, uncomplainingly, each session as though it were the first time he had been asked to do anything of the kind. He had a line he would use when researchers would thank him for his participation that has been quoted in many subsequent accounts. He would say, in various slight variations, that he was glad if what was being learned from him would help other people. The phrase was his own, or at least it had become his own across the many times he had offered it, and it appears to have been something he reached for spontaneously when the occasion of the testing seemed to call for it. Whether he fully understood the scope of what was being learned from him is a question that cannot be cleanly answered, because his understanding of any particular visit was bounded by the 30 or 40 seconds of working memory he could hold on to at any given time. But the line recurred across decades. He said it to Milner. He said it to Corkin. He said it to the many postdoctoral researchers and students who passed through the laboratory during his visits. Whatever he did or did not comprehend about the long arc of his scientific importance, some version of the altruistic instinct was intact in him, and it presented itself each time as though it were new. Brenda Milner, who by the 1980s was in her 60s and had largely handed over the primary investigation to Corkin, would still occasionally fly or take the train down to Boston to see him. She had known him by then for more than 30 years. She had written with him, tested him, co-authored the papers that had made his case famous, and followed him across the arc of her own career. When she walked into the testing room at MIT, he would greet her with the same pleasant courtesy he greeted everyone. He did not know her. He had not known her on the first visit in 1955. He did not know her on the last visit before his death in 2008. She would say hello. He would say hello. They would sit down together, and for a short while she would be in his presence again, and he would be unaware that they had ever been in each other's presence before. When he died, Milner, then 90 years old, was asked what the death meant to her. She answered, with what one imagines was a small, complicated pause, that it felt to her like the loss of a friend. The friendship had run in one direction for more than 50 years. In the other direction, across all of those years, it had simply not existed. What Milner felt at his death was, by any normal standard, a grief over someone she had known intimately. What Henry had felt about her, across the same period, was whatever a 30-year-old courteous young man feels when he politely greets a stranger who has just walked into the room. The asymmetry was absolute. And the asymmetry is, among other things, a kind of proof of how much of the ordinary experience of friendship depends on the continuous remembering that Henry could no longer do. Milner kept the relationship. Milner had no choice. The relationship lived where it could live, which was in her. The train across Henry's window kept passing. The paper mill kept standing empty. The rabbit kept sitting, sometimes on his lap in the courtyard. All over the world tonight, researchers are visiting patients they have been visiting for years, and the patients are greeting them with variable degrees of recognition depending on the nature of the patient's condition. In some cases, the greeting is warm and knowing. In some cases, it is courteous and empty, the way Henry's was. The scientific record built out of these visits is a record of relationships in which the two sides of the table have unequal access to what has passed between them. The researcher keeps the story. The patient sometimes does not. The science that emerges from such relationships exists because one side was willing to keep showing up to a situation the other side could not hold. This is not a thing the papers discuss. It is not the sort of thing that fits into the methods section of a journal article. But it is, underneath the methods section, the ground on which the work gets done. And in the case of Henry Molaison, across the 42 years of Suzanne Corkin's work with him and the 30-plus years of Milner's before her, the ground was held steady by two women who never, on any of the hundreds of occasions when they greeted him, were greeted back as anyone he had ever seen before. Somewhere in your head right now is the name Kennedy, and attached to that name is a network of other things, a particular decade, a city in Texas, a motorcade, an open-topped car, a figure waving from it, and then the terrible thing that happened in the middle of a late November morning in 1963. You did not have to work to assemble any of that. The name arrived, and the network arrived with it. The way things do when a piece of shared cultural knowledge has been sitting inside you for long enough that it feels almost like a feature of the world rather than a feature of you. Henry Molaison, by every prediction the standard theory of his condition would have made, should not have been able to do the same thing. Kennedy was assassinated in November of 1963, 10 years and 2 months after Henry's surgery. Everything the 1957 paper had established about Henry's condition said that he should not have been able to acquire new semantic knowledge after the operation. The machinery that would have encoded the name, linked it to the network, and consolidated the linkage into a persistent piece of general knowledge had been largely removed. And yet when Corkin's team, some decades later, presented him with a list of names and asked him to pick out the ones he recognized, Kennedy was on his list of recognitions. not every time, not with perfect accuracy, but often enough and consistently enough that the finding could not be dismissed as guessing. This was the first and one of the most striking of what Corkin and her colleagues would come to think of as the islands of preserved semantic knowledge. Small, scattered pieces of information about the post-1953 world that Henry had somehow acquired, and that the standard picture of his condition had not predicted he could acquire. The list of such islands, as it accumulated over the decades of testing, was not enormous. His semantic knowledge of the post-operative world was deeply impoverished compared to that of any ordinary person. He did not know, for example, who most of the presidents after Kennedy were. He could not identify most of the cultural figures who had risen to prominence after his surgery. Large portions of the world that had come into being during his 55 post-operative years were genuinely absent from him. But within that absence, certain specific things had, against all prediction, managed to take root. Lee Harvey Oswald was one of them. If Henry could identify Kennedy as a famous person, he could often also identify Oswald, and if pressed, he could sometimes connect the two names to the event that linked them. He knew in some partial and imperfect way that a president named Kennedy had been shot, and that the man who shot him had been named Oswald. He did not know the year. He did not remember in the episodic sense where he himself had been when it happened. But the connection between the two names and between the names and the event had become available to him. Something about the Kennedy assassination had been strong enough to cross the anatomical barrier that should have prevented its entry. Archie Bunker was another. As we touched on earlier, Henry, across his decades of watching the sitcom All in the Family at Bickford, had acquired a functional knowledge of the show's central character. Ask him about Archie Bunker, and he could say something about him. That he was a man who argued a lot, perhaps, or that he lived in Queens, or that he called his son-in-law Meathead. The knowledge was not deep. It was not the kind of knowledge a regular viewer of the show would have, but it was real knowledge. It had been acquired across repeated exposures over years, and it had stayed. Henry did not remember watching the show. He did not remember any particular episode. He could not tell you what had happened last week's episode or last year's. But the general contours of who the character was and what he did and what he was famous for, those had settled into him, quietly, across thousands of hours of passive consumption in a nursing home common room. There were others, the names of a few public figures who had become prominent after his surgery. A handful of historical events that had occurred during his 55 amnesic years, and that had been intense or repeated enough in the cultural atmosphere that something of them had stuck. When Corkin and her colleagues tested him formally on post-1953 semantic knowledge, using paradigms in which he was shown pairs of names, one famous and one random, and asked to pick the famous one, he performed significantly above chance, not at the level of a normal adult. Nowhere near that, but above chance. The above chance performance was the finding that mattered because chance was what the standard theory had predicted, and he was not at chance. Something was getting through. The question of how was the interesting one, and it has not been fully answered, though the contours of a partial answer did emerge across the later decades of his testing and became sharper still after the 2014 post-mortem analysis of his brain. One possibility, which Corkin raised in her 2002 review paper in Nature Review's Neuroscience, was that the acquisition of these islands depended on a combination of emotional salience and sheer repetition. The Kennedy assassination had been, for Henry, as for everyone alive in America in 1963, an event of overwhelming emotional intensity. It had dominated the news for weeks. It had been replayed on television. It had been discussed by everyone around him, his mother, his relatives, the nursing staff at the places he passed through in his medical life. Even without the hippocampus to do the normal work of consolidation, the sheer density and emotional weight of the exposure may have been enough to imprint the core facts in cortical areas that were still available to him. Repetition, above a certain threshold, may be able to substitute, partially and imperfectly, for the kind of consolidation the medial temporal system performs in healthy brains. The imprint would be shallower, it would be less richly contextualized, it would lack the episodic dimension that would let Henry say where he was when he learned of the event. But the semantic core of the event, the names, the basic what happened, might still be available through enough sheer repeated exposure to make its way into durable form somewhere outside the damaged region. The second possibility, which became more plausible after the 2014 post-mortem, is that the residual hippocampal tissue at the back of each temporal lobe may have been doing more work than anyone had realized. That tissue, remember, had been largely cut off from its normal inputs by the removal of the entorhinal cortex in front of it. But it had not been destroyed. It was still there, still histologically alive, still composed of the same cell types that define a functioning hippocampus. If some fragmentary input could still reach it, through alternative pathways, through the partially spared portions of the surrounding cortex, through the subiculum and the small remaining portions of the perirenal region, then it could in principle have been doing some small amount of the ordinary consolidation work on some small fraction of the information that reached it. Not enough to produce normal memory, not nearly enough, but perhaps enough to account for certain specific things that made it through when most did not. The posterior hippocampus has been linked in other studies of healthy brains to the encoding of less detailed, more schematic kinds of information, the gist of events, the general contours of facts, as opposed to the richly detailed episodic recollection that the anterior hippocampus specializes in. If Henry's remaining posterior tissue was doing some fraction of its normal gist encoding work, it might explain why he could retain the semantic core of major events without retaining any of their episodic detail. These two explanations are not mutually exclusive. Both may have contributed. It is also possible that cortical structures outside the medial temporal system entirely, regions of the anterior temporal lobe, parts of the prefrontal cortex, were doing work that, in the ordinary healthy brain, they share with the hippocampal system, but that, in Henry's damaged brain, they had to do more of on their own. The distributed nature of semantic memory, in general, has become clearer over the decades since Henry's case first drew attention to the medial temporal system. Semantic knowledge, the knowledge of what words mean, what objects are, who famous people are, is not stored in a single brain location. It is distributed across networks that span large portions of the cortex, with particular concentrations in the temporal lobes outside the medial surface. These distributed semantic networks had been largely spared by Scoville's surgery. Much of what Henry's preserved semantic knowledge of the pre-1953 world drew upon, and much of what allowed some post-1953 semantic acquisition to occur in him, was probably located in these extramedial cortical regions, supplemented by whatever partial function the residual medial tissue could still contribute. The picture that emerges, if you stand back from it, is less the picture of a pure amnesic than the picture of a patient with severe but incomplete damage to one subsystem of a broader memory architecture, whose other subsystems continue to operate in reduced but not absent ways. This refinement did not diminish Henry's importance to neuroscience. If anything, it deepened it, because it showed that the question of what memory is could not be answered by pointing at a single structure and saying, "Here." The answer had to account for a system, several subsystems, interacting, each with its own partial role, each with its own vulnerabilities and its own preserved capacities when other parts of the system were damaged. Henry's case, properly understood, became an argument for complexity rather than for localization. The localization was real. The medial temporal system was central. But it was not the whole story, and Henry, across 55 years of testing, kept showing his examiners that it was not. There is a second complication in the picture of Henry's preserved inner life that has nothing to do with semantic knowledge and everything to do with emotion. For most of the decades of his post-operative life, the public scientific account of him, as presented in textbooks and in Corkin's own writings, described a man of cheerful placidity. The phrase from the 1957 paper repeated across subsequent accounts. He was described as content. He was described as easygoing, accepting of his condition without distress, finding small pleasures in crosswords and television and the trains passing his window. This was the Henry who appeared in the scientific literature. It was not exactly wrong. It was what the surface of him, across the many observed hours of testing and visits, appeared to be. But there was a second Henry, visible only in certain specific assessments that were not prominently reported during his lifetime, and this second Henry has become a subject of scholarly attention since his death. Across his decades at MIT, Henry was given, among the many other tests he completed, the Beck Depression Inventory. This is a standardized self-report questionnaire, widely used in clinical psychology, in which the patient reads a series of statements and indicates, for each, which of several graded options best describes how they have been feeling recently. Henry completed this questionnaire on multiple occasions, in his own hand, across the years. The results, as they have been discussed in the literature since his death, tell a story that the surface of his cheerful placidity did not. On a number of the inventory's items, Henry circled the options that indicated significant depressive symptoms. He indicated on items assessing hopelessness that he felt the future was hopeless and that things could not improve. He indicated on items assessing self-worth that he felt himself to be a complete failure as a person. These are not minor or marginal endorsements. They are, by the clinical conventions of the instrument, indicators of meaningful depressive content. How to reconcile this with the cheerful surface is a real question, and it does not admit of a single easy answer. One possibility is that Henry's depression, whatever its depth, did not translate into the behavioral signs of sadness that observers would have noticed, the flat affect, the withdrawn manner, the complaints, and that its presence was visible only when he was asked directly, through an instrument designed to probe it. Another possibility is that the cheerful placidity was itself partially a function of his condition, that the inability to accumulate the texture of a continuous life had the side effect of flattening the ordinary oscillations of mood that a remembered life produces, so that what remained at the surface was a kind of default pleasantness, with the underlying melancholy accessible only when the right question was put directly to him. A third possibility is that both things were genuinely true at once, that he was capable of real moment-to-moment contentment in his immediate surroundings, while also, at a deeper level that was not continuously in his awareness, holding a real recognition that his life had been taken from him and that the future held no meaningful improvement. None of these possibilities is inconsistent with the others. All three may have been at work in different proportions at different times. What is clearer, and what the Beck inventory material insists we acknowledge, is that Henry's condition was not simply the untroubled contentment that some of the earlier accounts implied. There was a fuller person inside the affable surface, and that fuller person had, at least some of the time, a complicated and painful relationship to what had happened to him. He had, within the bounded 30 or 40 seconds of his working attention, access to some form of recognition that things were not as he would have wished them to be. He had, in the self-report of the inventory, the ability to say so. Whether he could hold that recognition long enough to suffer from it in the continuous way that ordinary unhappiness is suffered, that we cannot know. But the recognition was there. It was not invented by a later critic. It was written down, in his own hand, on a standardized form, at the laboratory of the researcher who had spent decades with him. The record exists. What we are left with, at the close of this chapter, is a more textured picture of Henry than the earlier accounts offered. He was a man with severe but not total amnesia. He retained, against the predictions of the simpler model, certain islands of post-1953 semantic knowledge, acquired through some combination of repetition, emotional salience, and the small residual function of the tissue that had been spared. He watched Amtrak trains pass his window. He watched All in the Family. He did crossword puzzles. He participated willingly in experiments and said, in his own words, that he was glad if what was being learned from him would help other people. And underneath the surface of all of that, in the self-report data of a standardized clinical instrument, there was a different and more painful self-assessment, indicating that some part of him, some of the time, knew exactly what had happened and registered it as a loss. Tonight, somewhere in your sleep, an emotional memory will reactivate that you did not choose. A feeling will return without its context. A mood will rise that has to do with something you had not been consciously thinking about. This is the ordinary integrative work of the sleeping brain. The process by which emotional tone, stored in limbic structures that are not only medial temporal but also extend into the amygdala and the related circuitry, is revisited and readjusted during the night. Your cortex is doing this without your consent, not unlike Henry, who also held on to feelings and partial knowledge that he had not consciously chosen to hold on to. The difference is that in your case, the feelings have names, histories, autobiographical anchors. In his case, the feelings were real, and the partial knowledge was real, and the autobiographical anchors that would have allowed him to say where the feelings came from were not available. The islands were there. The map that would have connected them to the rest of his life had been removed. What remained was a man who knew some things he should not have known, and felt some things he could not fully explain, and who, in the narrow window of working attention available to him, occasionally told a standardized questionnaire that he thought his life was a failure and that the future held no hope. If a person cannot remember from one day to the next that they have signed a piece of paper, have they signed the paper in any meaningful sense? This is the kind of question that sounds like a philosophical puzzle, but is in fact a practical matter in the ethics of medical research. And it is the question that sits at the center of one of the most painful controversies to have emerged from Henry Molaison's long scientific life. The controversy did not surface during his lifetime. It surfaced in the summer of 2016, 8 years after his death, when a journalist named Luc Dietrich published a book titled Patient H.M, a story of memory, madness, and family secrets. The book's publication, and the excerpt of it that appeared in the New York Times magazine a few weeks before the full volume reached bookstores, produced a reaction within the neuroscientific community that has few parallels in the recent history of science journalism. More than 200 scientists signed a public letter criticizing the book's portrayal of Henry's principal MIT researcher, Suzanne Corkin. The Massachusetts Institute of Technology issued a detailed institutional rebuttal. Colleagues of Corkin's at the Martino Center at Massachusetts General Hospital issued their own. Dietrich responded on his own platform. The exchanges ran through the late summer and autumn of 2016. And they did not produce a clean resolution. They have not produced one since. What the book raised, and what made the controversy unusually difficult to dismiss, was a set of questions that cannot be answered simply by defending any of the individual people involved. The questions are structural. They are about the ethics of research with patients who cannot, in any continuous way, remember giving consent to the research. They are about the relationship between a principal investigator and a subject whose dependence on that investigator deepens over decades. They are about the handling of scientific findings that complicate a long-running scientific narrative. And they are about who, in the legal sense, has the authority to make decisions for a human being whose own capacity to make those decisions has been compromised. Dietrich's book made specific accusations against specific people, and those accusations can be debated on their specifics. But underneath the specifics, the structural questions remain, and the structural questions apply not only to Henry's case, but to many other research subjects whose own capacity for continuous consent is limited. These are the questions that have continued to echo since the book appeared, even as the specific accusations have been contested in detail. It matters, before going any further, to name the complication at the heart of Dittrich's own position. He was not a disinterested journalist. He was the grandson of William Beecher Scoville, the surgeon whose operation had produced Henry's condition. His mother had been close friends, in childhood, with Suzanne Corkin, whose family lived in the same neighbourhood of Hartford. The book, as its subtitle signals, was in part a reckoning with his own family history, and the reckoning did not handle either his grandfather or his grandfather's former neighbour gently. Whether this makes the book more credible or less credible is not a simple question. Family proximity to a subject can produce insight that a more distant observer could not have obtained. It can also produce its own forms of distortion, old resentments, old loyalties, narratives shaped by what a particular person needed the story to mean. Dittrich is not an unreliable witness, but he is also not a witness without a position. Readers of his book and of the rebuttals to it have to hold both facts in mind at once. The closeness gave him access. The closeness also gave him a stake. The three specific accusations that drew the sharpest institutional response can be taken in turn. The first concerned a finding in Henry's brain that had emerged after his death from the post-mortem work led by Jacopo Annese at the Brain Observatory in San Diego. Annese's team, in the course of their 2014 paper, had identified a small but clearly circumscribed lesion in the left orbitofrontal cortex, a region outside the medial temporal lobe, and therefore outside the area that Scoville had been operating on. The lesion appeared to have been caused by the 1953 surgery itself, probably as a result of one of the surgical approaches used to reach the medial temporal structures. It was a small finding relative to the much larger medial temporal resection, but it was a finding, and it complicated the long-running description of Henry as a pure medial temporal case. Dittrich alleged, on the basis of early drafts of the paper that he had obtained during his reporting, that Corkin had tried to have the reference to this lesion removed from the published version, and that she had succeeded only partially. The lesion had remained in the paper, but in a form that Annese believed was less prominent than the finding warranted. The MIT response to this allegation was specific and documentary. Corkin had in fact been an author on the 2014 paper. The paper, as published, did discuss the orbitofrontal lesion in the abstract itself, which is the single most visible location in any scientific publication. The lesion was not suppressed. Whatever internal discussions had occurred among the co-authors during the paper's preparation, and there had indeed been discussions, some of them sharp, the final published document included the finding in a prominent place. The question of whether Corkin had pushed, in earlier drafts, to reduce the emphasis on the lesion is a different question from whether the lesion had ultimately been suppressed. And on the narrower question of suppression, the documentary record supported the MIT position. The lesion was published. The allegation of concealment, taken as a claim about what appeared in the scientific record, could not be sustained. The second accusation concerned the handling of Henry's research data, and here the dispute was harder to resolve cleanly. In an interview Dittrich conducted with Corkin in the late autumn of 2015, a few months before her death, Corkin had made remarks that Dittrich interpreted as indicating she had shredded, or was planning to shred, portions of Henry's research records. The remarks were recorded on tape. When the book appeared, MIT's response was that no records had in fact been destroyed, that Corkin, in her final illness, had in fact been working to organize and preserve the records, and that Dittrich's interpretation of her remarks was inaccurate. MIT also published additional material from the recorded interview, which included Corkin saying, at the end of the conversation, that they had kept the H.M. material. Whether the later remark outweighs the earlier one, or whether Corkin contradicted herself across the interview, or whether she was speaking loosely in one moment and precisely in another, is a question of interpretation. What the institutional record shows is that the data does exist, that it remains in the custody of the MIT Department of Brain and Cognitive Sciences, and that claims about destruction have not been supported by subsequent examinations. Whether the data has been made as available as independent researchers would wish is a separate question, and one on which some members of the broader research community have continued to press. On the narrow question of whether material was shredded, the institutional position has been consistent. The third accusation was the most structurally serious, and it is the one on which the controversy has continued to leave the longest shadow. It concerned the question of who had been Henry's legal conservator, and by what process that person had been selected. The situation Dittrich described was the following. From 1981 until 1992, according to information he obtained from Corkin herself, Henry was the only person signing the informed consent forms for the research studies he was participating in. This was a period in which Henry was, by every clinical measure, unable to hold the content of an informed consent conversation in his working memory long enough to meaningfully evaluate what he was agreeing to. He could read the form in front of him. He could answer questions about it. He would not, an hour later, remember having read it. Whether such a signature constitutes consent in the meaningful ethical sense, as opposed to the merely procedural sense, is precisely the question that modern research ethics has been grappling with for several decades, and it was as live a question in 1981 as it is now. In 1992, in consultation with MIT's legal counsel, Corkin arranged for a third cousin of Henry's, a man named Thomas Mooney, to apply to the probate court in Windsor Locks, Connecticut, for appointment as Henry's conservator. The court granted the application. From 1992 until Henry's death in 2008, Mooney was the person whose signature appeared on Henry's informed consent forms. Mooney also signed, some years before Henry's death, the document that authorized the posthumous donation of Henry's brain to research. Dittrich's concern on this front was twofold. First, that Mooney was not in fact Henry's closest living relative. There were first cousins of Henry's on his mother's side who were still living at the time Mooney was appointed, and those first cousins were, in the ordinary terms of kinship, more closely related to Henry than Mooney was. Dittrich argued that these closer relatives had not been notified of the conservatorship proceedings and had not been consulted about the research or about the posthumous brain donation. He had found them himself, he noted in the book, as a part of his own reporting, which implied that a similar effort by MIT in 1992 could have found them too. The MIT response was that the Mooney family had for many years been the family actually taking care of Henry. His mother Lillian had moved in with Mooney's mother, Lillian Herrick, in 1974, and Mrs. Herrick had cared for Henry until her own illness in 1980. And it was through her brother that Henry had ended up at Bickford. The continuity of actual caregiving, in the MIT view, was what made Mooney the appropriate person for the conservatorship, and the probate court had agreed after a formal hearing. Second, Dittrich noted that even after Mooney was appointed conservator, the follow-up contact between Mooney and Henry appears to have been limited. A lawyer conducting a routine conservatorship review in 1996 reported that she had been unable to reach Mooney and that the nursing home had also not had recent contact with him. Whatever the legal validity of the conservatorship, its texture on the ground appears, from this record, to have been thin. None of this can be resolved by adjudicating who was right. The MIT position that Mooney was a legally valid conservator who had been appointed through a proper probate process is correct as far as it goes. The Dittrich concern that the biological closeness of kinship was not the governing criterion and that a fuller effort to find Henry's closer relatives might have produced a different outcome is also not without grounds. What the controversy really exposes is the structural difficulty of the situation itself. A patient who cannot continuously consent requires a surrogate. The choice of surrogate carries ethical weight, and in the case of a research subject of unusual scientific value, whose access is controlled by the research institution, the potential for the surrogacy to align, unintentionally, with the interests of the research rather than with the interests of the subject is a real one. This is not an accusation against any particular person. It is simply a feature of the situation that any ethical framework has to contend with. Corkin, by every account of her own colleagues, was a careful and conscientious researcher who thought hard about these questions and who believed she was doing right by Henry. The MIT process that selected Mooney was a legal process conducted through the proper channels. None of that forecloses the question of whether a structurally different arrangement, an independent guardian at arm's length from the research, for example, or a more extensive effort to locate closer biological relatives, would have been ethically preferable. That question remains open. It is not a question against which any individual should be condemned. It is a question that modern research ethics, as it continues to develop, has a responsibility to keep asking. There is a fourth dimension to the controversy that does not sit inside Dittrich's specific accusations, but that the book raised by its own existence, and it concerns the gap between the public scientific account of Henry's inner life and what the unpublished clinical data appears to have contained. The cheerful placidity of the 1957 paper, and of the subsequent textbook treatments that drew on it, described a man who was, in the ordinary sense, at peace with his condition. The Beck Depression Inventory responses that Henry had completed across his years at MIT, the ones we touched on in the previous part of the story, told a different story, or at least a more complicated one. Henry had endorsed, on those self-report items, feelings of hopelessness and of self-assessed failure that were not consistent with the simpler public portrait. These responses were not hidden in any formal sense. They were in the research files, but they were not prominently reported during his lifetime, and the public portrait that circulated through the field was, in consequence, lighter than the private record. Dittrich brought this gap to public attention. Whether Corkin should have reported the depressive findings more prominently in her own lifetime, or whether the ordinary pace of scientific publication would have brought them to light eventually in any case, is a matter on which reasonable people disagree. What is not in dispute is that the gap existed. The public Henry and the private Henry, as disclosed in the self-report data, were not quite the same person. What all of this amounts to is not a verdict on anyone, but a deeper view of the conditions under which the science of Henry Molaison was produced. It was produced in a period during which modern research ethics was still developing, and during which many of the norms that now govern work with vulnerable subjects were being formulated for the first time. It was produced by people working, for the most part, in good faith, who cared about their subject and believed they were doing the work correctly. It was produced with access to a patient whose own capacity to hold the researchers accountable for their decisions was, by the very nature of his condition, severely limited. And it was produced inside an institutional environment in which the incentives of the research program and the interests of the subject, while usually aligned, were not always going to be identical and were not always going to be scrutinized by anyone outside the program with the authority to act on what they found. The result was a body of science of extraordinary importance to the field. The result was also a set of questions, surfacing painfully in 2016 after the principal investigator's death, that the field has had to reckon with since. Both things are the legacy. It is not possible to keep one without keeping the other. All over the world tonight, informed consent forms are being signed by people whose capacity to fully understand what they are agreeing to is, for one reason or another, incomplete. Some of them have cognitive conditions. Some of them are in acute medical crisis. Some of them are being asked to make decisions about experimental treatments whose risks and benefits have not been fully characterized by the best available science. This was not invented with Henry. It has not been solved since Henry. The ethics of research with vulnerable people is a practice in continuous development, conducted nightly in every hospital and every research institution in the world, and the questions it raises do not resolve into any final answer. Henry's case is not unusual for being ethically complicated. It is unusual for having been documented in enough detail, across a long enough period, that the ethical complications can be seen plainly. In most cases of this kind, the complications remain hidden, and the conscience of the practice has to do without them as a resource for its own improvement. With Henry, the record is there. Whatever one concludes about any particular decision taken inside his long researched life, the record itself is a kind of gift, however painful it is to receive. At 5:05 on the afternoon of December 2nd, 2008, at the Bickford Healthcare Center in Windsor Locks, Connecticut, Henry Molaison died. He was 82 years old. The cause of death was respiratory failure, a quiet ending after a series of medical events in the previous weeks that had gradually reduced what his body was able to do. He had been a research subject for 55 years. He had lived at Bickford for 28. Many of the staff at the nursing home had known him in their one-way fashion for years. Suzanne Corkin was at MIT when the news reached her. A plan had been in place for some time, coordinated with Jacopo Annese at the Brain Observatory in San Diego for what was to happen next, and the plan now went into motion. Within hours of Henry's death, his body was transported to the Athenula A. Martinos Center for Biomedical Imaging at Massachusetts General Hospital in Boston. The center's scanners, which could produce images of the brain at a structural resolution far greater than anything available during Henry's lifetime, were made available for the long session that followed. Through the night, his body was imaged in a 3 Tesla scanner. The team acquired a full set of standard clinical sequences, high-resolution anatomical scans at 1 mm isotropic resolution, and multiple averaged scans at a resolution of 440 micrometers, each slice thinner than the edge of a business card. This was the first time the inside of Henry's head had been imaged with this level of clarity. During his life, the metallic surgical clips that Scoville had left in place in 1953 to control bleeding during the operation had made magnetic resonance imaging complicated to perform safely, and for many years it had been delayed because of worries that the clips might move under the field. Those worries had eventually been worked through. Imaging had been done in the 1990s, but nothing at the resolution now becoming available in Boston that night had been possible before. The scans ran for hours. The images that emerged were the clearest anyone had ever seen of the geography of Henry's brain. Still in the skull it had occupied for 82 years. The next morning, his body was moved to the Massachusetts General Hospital morgue for autopsy. The brain was removed with the particular care the circumstances required. When it was taken out of the skull and weighed, it came to 1,100 grams, about 200 grams below what would have been expected for a man of his height, a weight deficit that reflected the combination of the original surgical removal, the decades of cerebellar atrophy caused by his long Dilantin use, and the smaller vascular changes that had accumulated in the deep white matter over his later years. Photographs taken at the autopsy show the brain from below, the inferior view, and in those photographs the region where Scoville's suction device had worked more than half a century earlier is visible as an absence on each side. Along the inner surface of each temporal lobe, where the hippocampus and the surrounding cortex would normally be, there is a cavity lined with pale, fibrous scar tissue that the surgeon's instruments had shaped in 1953, and that the tissue around it had been slowly healing against for the intervening 55 years. 2 small black surgical clips are visible in the photographs, one on each side, left in place by Scoville himself, as was common surgical practice of that period, to mark the bleeding vessels he had dealt with during the operation. They had stayed where he put them for 55 years. The body had healed around them. They were still there. After the autopsy was complete, the brain was placed into preservative and prepared for shipment to the Brain Observatory in San Diego, where Annese's team had been waiting for it. Annese had been selected for this work some years earlier, in conversations between Corkin and a small group of colleagues about how, when the time came, Henry's brain ought to be handled. The choice had not been obvious. There were several neuropathology laboratories in the United States that could have received the specimen and produced competent anatomical studies of it. What Anais offered was something more ambitious. His laboratory had been developing, over the preceding decade, a set of techniques for the complete histological sectioning of human brains and the simultaneous digital imaging of each section, allowing the reconstruction of the entire brain as a three-dimensional model at a resolution sufficient to examine individual cell layers anywhere in the specimen. The technique was demanding. It required specialized equipment, meticulous preparation, and the willingness to commit a laboratory to a single specimen for months of continuous work. Anais had built his program around precisely this capability, and he had made the case that Henry's brain deserved it. Corkin and her collaborators had agreed. The brain traveled to San Diego. It was embedded in a block of gelatin and cooled to the specific temperature at which it could be cut reliably into thin sections without fracturing. And then the preparation work began. The cutting itself took place a year after Henry's death, beginning on December 2nd of 2009. The choice of that date was deliberate. Annis's team had decided to start the sectioning on the anniversary of Henry's death, a year to the day, and to broadcast the entire process live on the internet, so that researchers anywhere in the world who wanted to watch could watch. The webcast began on the morning of December 2nd and ran continuously for 53 hours, through 2 nights and into the 3rd day, as the brain was reduced, slice by slice, from a single intact organ into a stack of individual sections. Each slice was 70 micrometers thick, approximately the width of a single sheet of tissue paper. Each slice was photographed as the cutting blade revealed the block face beneath it, so that the record of each section's appearance was captured in high resolution before the slice itself was mounted onto a glass slide and moved into long-term preservation. The total number of slices produced was 2,401. Of those, only 2 were damaged during the cutting, and about 16 others carried minor imperfections that would require careful handling in later analyses. The rest, nearly all of them, were preserved in the order they had been cut, numbered sequentially, and stored in a refrigerated archive at the Brain Observatory. The live stream of the cutting was watched by tens of thousands of viewers around the world across its 53 hours. Some of those viewers were neuroscientists with a professional interest in what Anais was doing. Many more were ordinary people who had heard, in the news coverage of the event, that the most famous patient in the history of brain science was being dissected in public, and who tuned in simply to see it. What they saw, if they watched for any extended stretch, was a quiet and methodical process. A technician at the cutting apparatus making adjustments, a camera capturing each new slice as it emerged, the slow reduction, over the course of days, of a familiar organ into a stack of increasingly posterior sections. There was very little drama. It was the pace and register of skilled laboratory work, which is mostly patient attention and very little spectacle, and yet the webcast turned out to be, for many of those who watched, unexpectedly moving. The patient whose case had built the modern field of memory research was, in full public view, being transformed into the physical archive that would let the field continue to learn from him for generations after his death. The act itself was clinical. The meaning of the act was not. When the cutting was complete, the real work began. Anis's team spent the next 4 years producing, from the photographic record of the block face and from the microscopy of the individual slides, a complete digital 3-dimensional reconstruction of Henry's brain. The reconstruction was not simply a pretty picture, it was a research instrument, a model that other scientists, anywhere in the world, could examine in detail from any angle, at resolutions approaching the cellular level. It allowed questions to be asked about the exact boundaries of Scoville's 1953 resection that had never been fully answerable during Henry's life. The MRI scans taken in 2008 had given the highest resolution picture of his brain anyone had ever had while he was alive. The histological sections, with the digital reconstruction built from them, went further. They could show, slice by slice, exactly where the surgeon's instruments had passed and exactly what had remained. And what they showed, when the paper describing the reconstruction appeared in Nature Communications in January of 2014, was more complicated than the accepted picture of Henry's brain had been for the preceding half-century. The 2014 paper documented for the first time with full anatomical confidence the finding that a significant portion of Henry's posterior hippocampus had in fact survived the 1953 surgery. Along both sides of his brain, the tail of the hippocampus, the back portion, farthest from where Scoville's suction device had entered, was still there, still recognizably hippocampal tissue at the cellular level, still displaying the characteristic layered architecture that identifies the structure. The spared length on each side came to about 24 millimeters, a substantial amount of tissue by any measure. This tissue had been disconnected from its normal inputs by the removal of the entorhinal cortex in front of it, and it had atrophied across the decades as a result of that disconnection, but it had not been destroyed. Henry, in the strictest anatomical sense, had never been a case of complete bilateral hippocampal removal. He had always been a case of partial removal with significant residual tissue. The earlier accounts, based on Scoville's operative notes and on the lower resolution imaging available during Henry's life, had described the resection as more complete than it in fact was. The 2014 reconstruction corrected the record. The paper also documented, as we have already discussed, the small orbitofrontal lesion on the left side, outside the medial temporal system, that had been produced by the 1953 surgery, and that had not been prominently reported during Henry's lifetime. And it documented, across the broader expanse of his brain, the distributed smaller pathologies that a brain of his age and medical history would be expected to show. Diffuse changes in the deep white matter consistent with long-standing hypertension, atrophy of the cerebellum consistent with his decades of Dilantin use, the various small changes that a life of his length and complexity would inevitably leave in the tissue. All of these findings, taken together, refined the portrait of what had actually been happening inside Henry's head across the 55 years during which his case had been the central case in the field. The portrait that emerged was not a simpler one, it was a more honest one. The hippocampal damage was real. The deficits it had produced were real. The theoretical significance of the case was intact. But the specific anatomy of Henry's brain, once it could finally be seen at the resolution his story had always deserved, turned out to be more complicated than the simplified textbook version had been able to accommodate. All of this work was carried out with a particular scientific ambition, which was that Henry's brain should not become the private property of any single laboratory. Anis's team built the three-dimensional digital reconstruction as an open resource, accessible through the Brain Observatory's web-based atlas so that any qualified researcher anywhere could examine the specimen in detail without having to physically visit the tissue archive. This was, by the standards of human neuropathology, unusual. Most post-mortem specimens of exceptional scientific interest are held at the institution that prepared them and are made available only to collaborators with direct relationships to that institution. Henry's was made available to anyone. The explicit argument was that the scale of Henry's contribution to the field was such that no single laboratory should own the anatomical record of it, and that the scientific community's ability to keep learning from him depended on the openness of the archive. The archive has remained open. In the years since 2014, researchers around the world have used it to address questions that could not have been addressed during Henry's life, and new work continues to appear as the methods for analyzing such specimens become more sophisticated. The physical tissue itself has moved across the years. For a long time after the 2009 cutting, it remained at the Brain Observatory in San Diego. In more recent years, as the long-term plans for its curation have continued to develop. The slides and associated materials have been transferred to Boston University for permanent archival storage. The transfer represents the settling of the specimen into what is intended to be its final institutional home, under the stewardship of a dedicated committee of researchers who have taken on the responsibility of maintaining the archive and of coordinating the continued scientific work that draws on it. A brief review published in the journal Hippocampus in early 2024 described the current status of the project and the plans for future studies, including work on questions related to the onset of dementia that Henry's particular pattern of damage is well positioned to inform. His entorhinal and perirenal cortices had been almost entirely removed, and those regions are, in the current understanding of Alzheimer's disease, among the first cortical regions to show pathological changes at the onset of the illness. What Henry's brain can tell future researchers about the role of these regions in memory and in disease is a question that has not yet been fully answered. The archive will allow it to continue being asked. What has happened to Henry Molaison in the 16 years since his death is something that in the ordinary course of a human life does not happen. His body was dispersed across a series of carefully designed scientific procedures into a form that outlasts his biography. The brain that was removed from his skull on the 3rd of December 2008 exists now as a stack of 2,401 thin sections in a refrigerated archive in Boston as a three-dimensional digital reconstruction accessible through a website, as a set of high-resolution MRI datasets housed at multiple institutions, as a set of photographs at the autopsy and at each step of the subsequent analysis, and as a long and still growing sequence of scientific papers that draw on all of the above. He has been, in a literal sense, multiplied. The private organ that governed his experience has been converted by the techniques of modern neuropathology and digital imaging into a public record, and the record will continue to teach the field long after everyone who met Henry is themselves gone. This is not a form of continuation anyone during Henry's life could have promised him. The conversation about the posthumous use of his brain, to whatever extent it was possible to have with him, would have had to be held in the bounded 30 or 40 seconds of his working memory, and whatever Henry understood of the plans would have slipped away before the next conversation could begin. The authorization for the brain donation was signed by his conservator, not by him, and we have already discussed the complications that this raises. What we can say, with whatever confidence the record allows, is that Henry himself, across the decades of his research participation, repeatedly and spontaneously said that he was glad if what was being learned from him would help other people. Whether the fine details of the long posthumous program of study he is now part of would have matched his own wishes, we cannot know. What we can say is that the spirit of that program, the use of his condition to advance understanding of the brain, was a spirit he endorsed across hundreds of occasions, in words that were his own. Right now, somewhere in the world, a researcher is examining a slice of Henry Molaison's brain on a screen. She is looking at a specific region that has just become relevant to a question her laboratory is working on. She has never met him. She will never meet him. She knows his name, and she knows the outlines of his story, but the man himself is a figure from history for her, 2 generations removed from her own career. And yet the tissue in front of her is as fresh in its preserved form as it was on the day it was cut. The researcher can zoom in, she can trace cell layers, she can measure distances between structures, she can ask questions of the specimen that Scoville and Milner could not have imagined asking in 1953, because the methods for asking them did not yet exist. And when she is finished with her question, the archive will still be there for the next researcher with the next question, in a slow, cumulative extension of the original case that neither Henry nor the field that grew around him ever set a limit to. The work goes on. The patient is gone. What remains is, in every sense, a record. Henry Molaison died on a Tuesday afternoon in the first week of December, with the late Connecticut light already turning toward evening outside his window at Bickford. He had been a research subject for 55 years. He had never, in any of those years, been able to hold the fact of his own fame in his working memory long enough to be troubled by it. He had never, in any of those years, been able to remember more than a few minutes into the past, or to plan more than a few minutes into the future. He had been, across the whole of his adult life after that September morning in 1953, a man living inside a very narrow window of present time, through which the world passed continuously without being retained. And when the window finally closed, at 5:05 on the 2nd of December 2008, the man inside it had lived longer in that narrow shape than almost anyone, before or since, has been asked to live. Brenda Milner was 90 years old when she heard the news. She had known him for 53 of the 55 years of his post-operative life. She had tested him, written about him, returned to him, continued to see him across the full arc of her career as he aged from a young man into an elderly one. Asked, shortly after his death, what the loss meant to her, she used the phrase that has attached itself to the moment ever since. She said that it felt like the loss of a friend. There is a small particular strangeness to that phrase, and Milner herself has occasionally acknowledged the strangeness in interviews over the years. The friendship had only ever existed on her side of the table. Across all of those visits, Henry had greeted her each time as a new person he had not met before. The accumulating familiarity, the shared history, the deepening of what the two of them had been through together, all of it had lived in her alone. And yet the phrase was not wrong. What she had felt across those 53 years had been a kind of love. It had been a love directed at a person who could not return it, because the capacity for return had been removed from him in 1953 by the same surgeon whose telephone call had, 4 years later, placed Henry in front of her. That a love of this kind is possible, and that it can be sustained for more than half a century without being reciprocated, is one of the things Henry's life, without meaning to, taught the people who cared for him. Suzanne Corkin had known him for 46 years when he died. Her grief was of a different shape from Milner's, because she had been with him more recently and more continuously, and because the day-to-day texture of his life at Bickford had been, for her, a familiar and beloved thing. She had visited him for decades. She had arranged the stays at MIT. She had watched him do the crossword puzzles in his wheelchair by the window, had spoken with him over breakfast during the long visits, had planned his testing sessions around the rhythms of his attention. When she went to Bickford in the days after his death, to collect whatever needed to be collected and to oversee the arrangements that had been made for the preservation of his brain, she was not going to a research subject. She was going to a person she had spent most of her adult professional life with. Whatever one thinks of the complications that would surface in the decade after her own death, what can be said with some confidence is that she felt his loss as a loss, and that the part of her career that Henry had occupied had not been from the inside, the simple matter of scientific productivity that the critics would later characterize. It had been a long attachment to a specific and unusual man, carried out on terms that only she could hold across 46 years of her life. The bilateral medial temporal resection that produced Henry's condition had been performed, as we have seen, on the understanding that the limbic structures of the medial temporal lobe might be the source of his seizures, and that their removal might reduce his epileptic burden. The first of these hopes was partially fulfilled. His seizures did diminish, though they did not disappear entirely, and the severity of his attacks was reduced enough that his anticonvulsant medication could be lowered, and his intellectual capacity, freed from the sedating effects of the higher drug doses, could appear more clearly in the years that followed. The second hope, of course, the unstated hope that he would emerge from the operation otherwise intact, was not fulfilled. What emerged instead was the condition that made him, across the subsequent half-century, the most studied patient in the history of neuroscience, What he taught the field in the course of that study is a body of knowledge that would take longer to fully enumerate than any single chapter could accommodate, and so it has to be summarized at the end in the gentlest compression. He taught the field that memory is not a single diffuse property of the brain as a whole, as the dominant theoretical position of the mid-20th century had held, but a set of functions with specific neural substrates that can be cleanly damaged by the removal of specific anatomical structures. He taught the field that within what we call memory there are at least two functionally distinct systems, one dependent on the medial temporal lobe and one dependent on other structures entirely, and that these two systems can be separated so completely that one can be lost while the other continues to operate undisturbed in the same brain. He taught the field that the relationship between short-term retention and long-term storage is a relationship of sequential stages, each with its own requirements, each capable of failing independently of the other. He taught the field that the hippocampus and its surrounding cortex are required for the consolidation of new declarative knowledge, but that older memories, once consolidated, can survive the destruction of those same structures and remain available for decades after the machinery that originally built them has been removed. He taught the field that skill learning, classical conditioning, and priming are forms of memory that do not require the medial temporal system at all, and that these forms can continue to accumulate across a lifetime, even in a patient in whom declarative memory has ended. Every textbook of memory research published in the 68 years since the 1957 paper contains, somewhere in its opening chapters, a description of Henry Molaison. The field exists in its current shape because of him. But the mechanism, however thoroughly we eventually come to understand it, is not the whole of what his case is. Underneath the mechanism, through all of the 55 years, there was a person. The person had been 27 years old in September of 1953. He had been 82 years old when he died. He had been, during the years in between, a quiet man with a gentle sense of humor, a fondness for crossword puzzles, a willingness to participate in whatever tests the researchers brought to him, and an instinct toward kindness that survived intact through everything else he had lost. He had watched Amtrak trains pass the window of his room at Bickford, and each train, for him, had been the first train he had ever seen. He had watched a sitcom about a working-class family in Queens, and the character of Archie Bunker had become, across thousands of hours of passive consumption, a small island of partial semantic knowledge inside the larger amnesia. He had, when asked what he thought was being gained from the research he was part of, said in various forms that he hoped it would help other people. He had, when the right question was put to him in the form of a standardized self-report inventory, indicated that he felt the future was hopeless and that he felt himself to be a failure as a person. All of these things had been true of him at different moments, and perhaps at the same moments, across the 55 years. He had contained, as every person contains, more than the surface allowed the observers around him to see. This is the place in the story where the science and the life part ways, and where what the science can tell us reaches its boundary. The medial temporal lobe memory system, the hippocampus and its neighbors, the consolidation mechanisms and the declarative-non-declarative distinction, and the cortical networks that support semantic knowledge across the distributed architecture of the brain. All of this can be described, measured, imaged, modeled, and refined. What cannot be described by any method the neurosciences possess is what it was actually like for Henry to live inside the condition the mechanism produced. We know the shape of the absence. We do not know the shape of the experience of the absence. The two are not the same thing, and the gap between them, visible everywhere in the philosophy of mind but visible with particular starkness in Henry's case, is the place where the explanatory power of the science reaches its current end. He knew something about his own condition because he said so on the Beck inventory, and because he sometimes, when new tasks were introduced, looked briefly anxious in a way that suggested a partial awareness of his own discontinuity. What he did not know, or perhaps what he could not say, is what it had been like to live for decades as a man whose each new moment arrived without the moment before it as its preface, and whose each existing moment would depart without being carried forward. This was his life. It was the only life available to him after the 1st of September 1953. And the inside of that life is the one part of his story that his story itself cannot reach. Which brings us to the question that has been underneath all of this, the question that this story has been circling since its opening, and that it is now time to name, gently, for the first and last time. What is it that makes a person the same person from one morning to the next? We assume, most of the time, that the answer is the thread of remembered experience, that I am the same person who woke up yesterday because I can remember yesterday, because the memory binds the present moment to the previous moment and the previous moment to the one before that, and because the binding, running continuously across all the hours of a life, produces the felt continuity we call being a self. Henry's case unsettles this assumption in a way that few other cases have. Henry could not bind. He could not carry yesterday into today or today into tomorrow. The thread of remembered experience, as the rest of us live it, had been cut in him, and yet he was recognizably a continuous person across 55 years. His kindness persisted, his sense of humor persisted, his particular quiet manner, the thing that had made his mother and Milner and Corkin and the Bickford staff recognize him across the decades as the Henry they knew, persisted. Something in him held together without the thread. Something else, something below or behind or beside the thread of declarative memory, was doing the work of keeping him the same man through a life in which the ordinary scaffolding of that sameness had been taken away. What that something is, the neuroscience does not currently know. It is possible that the procedural systems, the emotional circuitry, the distributed semantic networks, the slow-changing patterns of personality that are encoded across the whole cortex, rather than in any single structure, were enough between them to sustain a recognizable person without the usual help. It is possible that selfhood is less a matter of continuous remembered experience than the rest of us have assumed, and that Henry's life, difficult as it was, demonstrated this by running without the assumed ingredient for longer than anyone had ever been asked to run without it. Or it is possible that what Henry was, the continuous man his caregivers recognized, was held together by something we have not yet discovered how to describe, a kind of coherence that persists in a human life even when the mechanism that would usually support that coherence has been removed. Henry's case does not answer the question. Henry's case reveals, more clearly than almost any other case could, that the question is the right question to ask. What it is to be a continuous person is a question that the ordinary scaffolding of an ordinary life normally hides from us, because the scaffolding holds, and we never have to look at what lies underneath it. In Henry, the scaffolding fell away, and the man who remained stood where the scaffolding had been, still recognizable, still himself. What had been holding him up, and what is always holding the rest of us up underneath whatever we think is doing the work, is a question his life posed and did not answer. We are left with the posing. We are left also with the 55 years during which his life, without his being able to know it, made the posing possible. Henry is now in more places than any person has ever been. His tissue is in Boston, slide by slide, in a climate-controlled archive. His three-dimensional digital brain is online, accessible to anyone with a browser and a reason to look. His name, or the two initials that stood in for his name until his death, appears in something close to 12,000 published scientific papers. His case is taught to medical and graduate students in every country where neuroscience is studied. Somewhere in the world tonight, a researcher is looking at a slice of him on a screen. Somewhere in the world tonight, a student is reading about him for the first time. None of this reached him. None of it could. He did not know, while he was alive, that he was becoming one of the most important patients in the history of his field, because the knowledge could not be held by the memory he no longer had. His fame is a fact about the world. It was never a fact about his life. There is a kind of immortality that is also a kind of exile, the immortality of mattering enormously in a place one is not able to enter. Henry mattered in that place for decades before he died, and he has mattered there with steadily increasing depth in the 16 years since. He did not know. He could not know. Whatever continuity exists between the Henry who sat in his wheelchair at Bickford and the Henry who appears on Neuroscience slides tonight is a continuity held entirely by the people who study him. In him, the two were not connected. In him, they could not be. The gap between what the world knows of a life and what the life knows of itself is present in every human story, but in Henry's, it is not a gap. It is a chasm. The world knew and knows a great deal. Henry knew almost nothing of what the world knew. Both facts are part of the same life. Both facts have to be held together, and there is no resolution of them into a single simpler story, because the life was exactly this shape, and no simpler shape will describe it accurately. Tonight, as you lie listening, the structures Henry lost are running, quietly, inside your own head. The current of experience that is passing through you now, the sound of my voice, the feel of the bed or the chair you are in, the particular quality of this particular moment is being sorted by machinery you will never directly observe. Some of what you are hearing will be consolidated, some will not. You are not being consulted. The sorting is automatic, as it has been every night of your life, and it will continue to be automatic through every night that is still ahead of you. By the time you wake, some fraction of this hour will have been woven into the longer record of who you are, and some fraction will have been allowed to release. The woven part will be there tomorrow. The released part will not. This is the ordinary equipment, running on its ordinary schedule, doing its ordinary work. Henry did not have it. For 55 years, the sorting did not run, or ran only in the reduced and partial way that the sparing of certain tissues and the activity of non-medial systems allowed. Each of his nights ended the way every night ends for all of us. None of his mornings began the way ours do, and across the whole of that long stretch, he participated, patiently and courteously, in the testing that would let the rest of us understand what the ordinary equipment is for and why it matters. Somewhere tonight, a person is dying in the same kind of quiet way Henry died, surrounded by people who have cared for them across years. And the record of that life, like the record of every life, will persist in the minds of those who remain and in whatever marks the person has left on the world. None of us will know, in the end, the full shape of what our own lives have meant to the people around us, or to the larger currents that run through our particular moment of history. Henry certainly did not. He could not. He worked with what he had, which was very little in terms of continuity and very much in terms of patience, and he helped a field of science come into being that would continue without him, that continues now, that will continue after all of us. He lived 55 years inside a window that closed behind him every few minutes. He did not know he was famous. He did not know he mattered. He did not know that his name, the two initials of it, would be read aloud tonight in quiet rooms all over the world by people who would never meet him, but who would come to care about him through the long and careful record of what had been learned from him. What remains is the record. What remains is also the man the record was built around, who was kind, who was funny in small ways, who liked the trains, who did the puzzles, who greeted every new person he met with courtesy, and who was, across the whole of the strangest life the 20th century made available to any single human being, recognizably, unmistakably, himself. Let the brain take over from here.